Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as treasurer of the World Federation of Neurosurgical Societies, the WFNS, in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CANSUR. I'm glad to tell you that with my team, I already organized 53 webinars, including many educational WFNS symposia. Today is webinar number 54, and I'm glad that this webinar is organized with my friend, Professor El-Ghandour, President of the Craniovertebral Junction and Spine Society. First of all, let me welcome all our keynote speakers. I will go by the order by which they speak. Professor Ashish Suri, he is professor at the Department of Neurosurgery, India Institute of Medical Sciences, New Delhi, India. Professor Takio Goto, he is professor at the Department of Neurosurgery, Osaka City University, Osaka, Japan. And he is chairman of the Neuroendoscopy and Neuroendocrine Committee of the World Federation of Neurosurgical Societies. Professor Kazuhiro Hongo is professor at the Department of Neurosurgery, Shinshu University Hospitals, Matsumoto, Japan. Professor Oscar Alves, he is chief of the Department of Neurosurgery Hospital, Luizada, Porto, Portugal. Professor Vladimir Binis is professor and chairman emeritus Department of Neurosurgery, Charles University, Prague, Czech Republic, and he's co-chairman of the Neuroanatomy Committee of the World Federation of Neurosurgical Societies. Professor Atul Goel, he's chairman at the Department of Neurosurgery, Lilavati Hospitals and Research Center, and he's professor at Cooper Hospitals and Medical College and at Mumbai Hospital Institute of Medical Sciences, Mumbai, India. Professor Albert Sofianov, he is chief physician and medical director of the Federal Center of Neurosurgery in Russia, and he is chairman of the Department of Neurosurgery, First State Medical University, Moscow, Russia. And finally, Professor Louis Borba, he is chairman at the Department of Neurosurgery, Federal University of Paraná, Brazil, and he is past president of the Brazilian Neurosurgical Society, and he is current chairman of the Education and Training Committee of the World Federation of Neurosurgical Societies. And we have the last two speakers. Professor Giuseppe Lanzino is professor at the Department of Neurosurgery, Mayo Clinic, Rochester, Minnesota, United States of America, and Professor Juan Carlos Fernandez. He is affiliated to the Department of Neurosurgery, Stanford University Hospitals, California, United States of America. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. Our program for today is outstanding. It's divided into two sessions. In each session, we have 5 distinguished speakers. Each talk is 15 minutes, and we have 10 minutes discussion at the end of each session. As you can see, all the topics are very interesting. This, as you can see in this screenshot, that until yesterday, we had 526 registrants over Zoom. We are also doing live stream over the Facebook page of the CANSUR. The address is seen over the screen, over YouTube channel of the Egyptian Society, and over the Neurosurgical TV. In this occasion, I would like to thank John Bennett. He's actually doing a great job in promoting our series of webinars. To all attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or the Q&A. We are offering this type of certificates. Remind you that this event is recognized by the World Federation of Neurosurgical Societies, and the certificate is approved by the World Federation of Neurosurgical Societies as well. Important announcement that in all our previous webinars, participants were printing their certificates electronically. However, some participants encountered some problems. My IT team are using new method by which certificates will be sent to emails automatically after the webinar is finished. So no need to print certificates. And it's important to tell all attendees that certificates will be sent only to participants who participated for at least 1 hour. For example, last webinar 53, certificates were sent only to 122 out of 365 attendees. Another important to mention that names will be written according to the name in the account of your email. Please register from your personal email. Webinar 55 takes place on Friday, 10th December at usual time. It's a collaboration with the Neuro-Oncology Division at Miami University. Also, I'm glad to tell you that the Pan-Arab Journal of Neurosurgery had been relaunched after a period of silence of 10 years. I am honored to be the editor-in-chief of this journal. We already published an issue in June. The second issue will be published next week, which is the issue of December. The address is seen over the screen. Submit your articles. Submission and publication is free. I'm also important to announce about the World Congress in Colombia, in Bogota, which will take place March 13 to 18, 2022. That is a very important event, and I encourage and I invite all of you to participate in this important event. Another announcement is the Third Man's Congress, which takes place in Egypt, 27 to 30 October 2022. I'm glad to be the president of this Congress, and I'm glad to welcome Alberto De Letala. He is president of the Mediterranean Association of Neurological Surgeons, the MANS. Thank you very much. Of course, all of you are attending, are invited to participate in this important event. I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much for attention. Now I give the talk to Professor Atul Goel to say his welcome speech. And after Professor Atul Goel, I can see that Professor Mahmoud Khorashi, president of CANS, is joining. Maybe he say his welcome note as well. Please, Professor Atul Goel.
Hello, Nasser.
Atul, how are you? Thank you for joining. I know you had some difficulty.
A lot of echo. I don't know.
Hassan, IT, there is echo.
Maybe.
I think he is opening two accounts.
Let me see. Hello, now it's better. Can you hear me?
Yes, it's very good now.
Yeah, sorry, because there were two windows open.
Yes,
so, Nasser, should we start the meeting now, you think?
Yes, we are already live. We are waiting for your welcome note, please, Atul.
Okay, so I'm very happy and very proud to see my dear friends, dear colleagues, and the people who I like, who I admire, and I think that they are suitable for this international lecture around the screen. They are not my friends, they are my colleagues, and they have been with me for a number of years. So with great pleasure and great honor, with Nasser at the top of the leading this huge webinar series and the leader of neurosurgeons of all over the world. Nasser is the too many achievements of Nasser, we all know, I don't want to say. So with these few introductory remarks, I wish that we start our program.
Thank you very much. Atul, maybe if you just give few minutes to Mahmoud Khorashi to say a welcome note as well. He's president of CANS. Mahmoud, can you hear me?
Thank you very much, Nasser. Thank you very much, Atul. This is an amazing galaxy of speakers that you have managed to gather from across the globe at various time zones and from the center of Africa, which actually is the cradle of mankind. I am really pleased, Nasser and Atul, that you're bringing a special series for our societies and our young trainees in the Continental Association of African Neurosurgical Societies. Really, the amazing number of webinars that you have put forward for them is testimony to your desire to educate. And every one of the people who are here are actually very regular in all the series that CADS has organized. So we thank you from the bottom of our heart on behalf of our societies, our young neurosurgeons, and the not so young as well. So over to you, Nasser and Atul, for enlightening us on this amazing subjects that you have put together.
Thank you very much. Professor Atul, would you like to start our scientific sessions and introduce our first speaker?
Yes. So our first speaker is Professor Ashish Suri, and he's a very accomplished neurosurgeon from the premier institution of our country. And he has been not only a very accomplished and very talented neurosurgeon, but also a teacher of teachers. He has organized some phenomenal workstation-based training programs in his institute, which Nasir, I wish that you relate this message to CANS and other societies all over the world, where there are, and actually I will like Ashish to briefly introduce your training program, because my feeling is that training program that he organizes and teaches young residents from all over the country and all over the world is absolute beauty. And this training program is led by Dr. Suri. He's my good friend, my dear brother, and I'm sure we will all learn from what Ashish has to say. Ashish, please go ahead. First, introduce a little bit about yourself, then about your program, and then your lecture. Ashish.
Yeah. Thank you, Professor Goel. I'll just share my screen as well. Thank you, Professor Goel, Professor Nasir, Professor Mahmood, and all the senior and the very accomplished faculty here. And is my screen visible? Yeah.
Yes.
So,
yes.
yeah. So I'm actually, this is where I belong. I belong to I've been serving at the All India Institute of Medical Sciences, New Delhi, India, from the last 28 years now, and close to 3 decades. It's one of the biggest hospitals in the country with the biggest training programs. We have nearly 52 residents and fellows. We operate close to around about 5,000 surgeries per annum with a gamma knife, with mobile CTs. My personal interests are that we have around 25 faculty, and it's an established department for the last now 55 years. And my personal interests are skull-based surgery, vascular neurosurgery, endoscopic neurosurgery, neuro-oncology, and epilepsy surgery. I do a lot of research in neurosurgery simulation and neuroengineering and neuro-oncology. And like at the end of the lecture, I'll briefly tell what exactly I do in my training program. So I'll just start. Thanks for the kind words, Dr. Goel. So I've been assigned the Petrus Apex rhomboid approach. This is an approach which is very close to my heart. I'm taught by my teachers, Professor Kavase and Professor Winker-Dollins, and it can take care of a spectrum of lesions, a very wide spectrum of lesions. And just a second, yeah. So yeah, we'll be talking about this area, the clivus and the Petrus apex and the cavernous sinus as well. This is the area which we have lateral to carotids and the clivus and the Petrus this approach is centered around the posterior clinoid process and the Petrus apex. And it's a big, it's a small area with a lot of complex nerves and vessels. So this is the standard Kawase's posterolateral triangle, posteromedial triangle. And this is what the approach is. It is a standard position with either an extension of a pterional or a temporal craniotomy, but with a degree of rotation, whether you are focusing on the cavernous sinus or on the posterior clinoid process. And I sometimes do an OZ or an FTOZ, depending upon the lesion, if it is more anteriorly or posteriorly placed. Usually the FTOZ is more of a single piece. Most of the FTOZs are a single piece. And the main aim is to convert a triangle into a rhomboid. That is, once you expose the whole cavernous sinus, right from V1 to 3-4, and mobilize the fifth nerve. That is the main aim. So you convert the triangle, which was a narrow triangle between the petrous at the petrous apex, but the petrous, the posterior clinoid and the sixth nerve, the Droller's canal used to not be so much visible, and then you convert into a rhomboid. And these are the steps which I'll be showing. We did a volumetric analysis of comparison of this triangle versus a rhomboid, and we realized that it was nearly 2.5 times much more bigger than the standard triangle, which was already described by various authors. And we published this in around about 6 years ago in Journal of Neurosurgery. The good thing about having a rhomboid approach is there's less retraction, direct retraction of the posterior temporal lobe. There's more of an anterior retraction. You're working at an angle. And the steps which are different is there's more mobilization of the cavernous sinus right till the V1, that's the superior orbital fissure. And also there is a good dissection over GSPN, so you can actually save it. And then you can mobilize the fifth nerve. That is another, so you, actually this is what the vision that you get. There's a complete Cassian ganglion and the Meckel's cave. There's a Cavazis rhomboid. The spectrum of lesions that you can take care of this, from extradural lesions like chordomas, chondrosarcomas, angiofibromas, intradural lesions like schwannomas, and intradural lesions like meningiomas, aneurysms, collection of petroclival meningiomas, small ones, the large ones, in which you can actually go into Meckel's cave as well through this anterior transpetrous rhomboid approach. And this is another petroclival meningioma. And this is a direct approach. I don't like going retrosigmoid or complete petrosal, though I'm a big fan of Dr. Ohata's retroauricular, labyrinthine approach. But I feel that for these tumors, this is a very good approach, an anterior approach, because all the nerves are anterior. Plus, if it is going lateral to the internal aortic canal, so these are some of the cases. If you, in such a tumor, if it is going lateral to the canal, I combine this approach with a standard retrosigmoid. So you can actually save the hearing as well. Just a short video of a large petroclival meningioma that we actually see very often. So this is a standard temporal incision which goes down the zygoma, and do a temporal craniotomy with a zygomatic osteotomy, take off the temporal base and the superorbital fissure, lateral wall superorbital fissure, and then open the Cassian ganglion. So open the foramen spinosum, visualize the middle meningeal artery, and then we were actually dilating the foramen spinosum. That is the V3, and then coagulate the middle meningeal artery and then divide it. Then do a separation of the V3 and then trace it down to V2. Then that is the sharp dissection, sharp and blunt combined over V2 and V3 and V1. Posteriorly, you have to be at close, very meticulous at the GSPN. So you have to separate and leave an endosteum over the GSPN. And that is the petrous rhomboid, bounded by the arcuate eminence, the petrous ridge. And we're drilling, initial drilling with a cutting drill and then solid diamond. Then a basal temporal urotomy, and then make a T down the superior petrosal sinus. And that is the tent. And behind the fourth nerve, we cut the tent right till the superior petrosal sinus. And that is the superior petrosal division of the superior petrosal sinus. And with some, usually you don't need live eclipse, but unless it's large, you can, then you need some live eclipse there. And you open the posterior fossa as well. And then you're right on the tumor. This was a difficult tumor. So fibrous. And decompression and then dissection. Then separation of the fourth nerve. Fourth nerve is usually, it is something, what I'll What I've learned is fourth nerve can be stretched, but it cannot be in its path because it's always stretched by the tumor, but it cannot be stretched at its where it exits the tentorium. Then decompress, dissect, decompress, dissect. And that is its dissection from the brainstem. And that's where the fourth nerve is exiting from the tentorium into the system. Combination of, you have to actually dissect, most of the time you're using a long forceps to dissect it from the brainstem perforators. That's the most important key. Right? These are the perforators that is important. You cannot sacrifice these perforators. If you cannot dissect them, it's better to leave some tumor there. And that's a dissection of the trigeminal. You can see the trigeminal now. And then you can actually go to the real petrous apex, and that's the fourth nerve. Anteriorly, you can go to this third, and also visualize the sixth. We could remove the whole of the tumor, and then a basal dural closure. Some part is open because we removed the bone and that we plug with fat graft. I haven't had any CSF leak with this approach. It's a combination of fat and fascia. Glue is more of a, so that is where. So this is my personal experience. So with nearly more than 80% with a standalone approach with a combination of retrosigmoid and other few cases, and gross total with near total excision in close to 2/3 of patients. New cranial nerve deficits, most of them temporary, with third and sixth and fifth. Sixth is one which is most dangerous. This is what we analyze with univariate analysis, that extent of resection is directly proportional to the brainstem compression and brainstem edema, presence of an arachnoid plane, and T2 hyperintensity in the brainstem. But multivariate analysis, the T2 hyperintensity in the arachnoid plane were the most important. Immediately on discharge, we found that nearly, you can say around about 78% of patients were either improved or same, but most of the patients were improved or same at discharge. I'll just go to the other one. Yeah, we use this approach for a big spectrum of lesions, for chondrosarcomas, for chordomas, and this is a chondrosarcoma which I operated in a 60-year-old lady a month ago, and this was a calcified tumor. Sorry. So it's a lot of burrows because the dura was stuck to the bone, and we separate the. We are at the foramen spinosum. The same steps. I'll just rapidly expedite this portion, and then the drilling of the rhomboid, and then division of the superior petrosal sinus. The tumor was very calcified, and this is where I actually relied on using a bone QSA. And if you see, this is like a stone once we open the tentorium. And we tried to drill it, but it was so mobile. So that was the bone QSA, which we used it to cut it, and then we could take out small portions of that. It was stuck to the fifth nerve and the base of the sixth at the Dorales canal. And this was like a stone hanging in the middle, stuck to the brainstem. And then dissect, and then again scallop it with the bone QSA. Please let me know if I'm a bit late, and then I can skip some slides. And then this is the free portion. And again, and then this could be removed.
Ashish, maybe 2 or 3 minutes more.
Right, sir. And that is the entry where it was going into the sphenoid sinus. I think I'll just skip some slides and plug it with fat, and that is the complete excision was performed. We used this approach for 2 of these cases, giant complex P2 aneurysms, 1 basilar complex, and we did a STA-PCA bypass. And this was the shortest route for the superficial temporal artery to go right onto the PCA. And we could, there was an end-to-side anastomosis. And I think this is harvesting of the STA. And then again, the petrous rhomboid. And the same approach, division of the superior petrosal sinus, visualization of these are all both failed embolizations. So we resorted to putting a bypass and then trapping the aneurysms. It's always continuous anastomosis in the depth. And then checking with ICG and then trapping it and confirming with, yeah, that's a I skipped this basilar aneurysm. We've used this tumor in dumbbell-shaped schwannomas, and I skipped this video. Then multi-compartment epidermoid. We realized that this is the only approach that if there's a epidermoid going into bilateral CP angles and middle fossa, you can, and even supercell assisted, you can use that. This was a case which we reported in child nervous system as Rosai-Dorfman, which was a bilateral histiocytosis. And I am also a big fan of Hakuba's, that most of craniopharyngiomas, if the epicenter is posterior, you have to go. I usually do this approach for giant multi-compartmental, especially the posterior fossa extension of these tumors. So this anterior transpetrous rhomboid approach has a vast spectrum, like I showed. But you have to master the anatomy, cadaver training, microsurgical skills, arachnoid dissection, high-speed drilling, and just a brief outline of what we do as training. Actually, I love to teach, and we have a training school, which was, I inherited from my teachers, which was started 40 years ago, but I was handed over 20 years ago, and now it is a 3D microscopic endoscopic lab. And we resorted that 1 day or 2 day workshops actually are not the right thing. So we condensed them down to 2-week or a 4-week skills training program. We've trained more than 1,200 neurosurgeons, a lot of workshops with WFNS associations on the neuroendoscopy, as well as the skull base and the anatomy teams. And probably the cheapest workshop, it's just less $20 for third world countries and $100 for the rest. We have trained from neurosurgeons. Even the COVID, we've been active with social distancing. And this is a small video of what we actually do. This is in Delhi. These are my teachers who started this lab more than 40 years ago. And now I'm just a thread. There are multiple pearls, and you can see many national and international faculty. We've had and this is Martin Bittag. We've had an Indo-German collaboration and an Indo-Japanese collaboration with Dr. Ohata, led by Dr. Ohata. And this is for teaching of neurosurgeons, and even to stimulate my young surgery registrars to take up neurosurgery in future. The microsuturing and high-speed drilling, endoscopy. And it's not only teaching. We collaborate with the technology institutes to develop platforms in which we can assess or evaluate whether the simulation is not only training. We are using a lot of AI, machine learning, deep learning platforms for actually evaluating whether
Ashish, we may have to stop now.
Yes, sir.
Please.
Yes, sir. So with folded hands, I've already thanked you. So no matter. So this is the message. So I will be replaced. All of us are being replaced. So maybe there'll be more technology which can change how these petrous and these cavernous sinus tumors can be operated. Thank you. Thank you.
Okay, Ashish. apart from the technical work that you have done, apart from the surgical approaches that you have shown, there's no question this teaching program and all the things that you do will be a good information for the neurosurgeons all over the world. So now I take you to my another young, no longer, I'm not sure, Dr. Goto, how young you are or how old are you, but I only know that there is a big lineage of his department. Professor Hakuba was the chief, then Ohata was there, and both of them are big proponents of fine skull-based surgery. Nasir knows both of them, and they are very respected throughout the world. Hakuba, of course, my dear friend. Ohata, of course, my dear friend. And now we have another generation of wonderful technical neurosurgeons. And one of them is Dr. Goto. And I have no doubt, and you will see yourself, the technical power of Dr. Goto. What he has done is he has modified the approaches of Ohata and Hakuba from pure skull base to endoscopic included. He also does skull base, and now he does for specific cases endoscope and skull base. So let us all see, Dr. Goto, what you have to say. And it is indeed mine and Dr. Nasir's great pleasure to have you on board, Professor Goto from Osaka City Hospital. Goto.
Thank you, Goel. At first, I would like to share my screen. Okay, can you see my slide?
Yes, very well,
Okay.
very well.
Okay, today I feel very honored to have the opportunity to present my work in front of many experts of skull-based surgeon. Today, my topic is endoscopic transcribal approach to large lower cribus meningiomas. At first, I will introduce my institute. Osaka City University is one of the large skull-based centers in Japan. So the Professor Hakuba started a combined transpetrosal approach for resection of large petrocribal meningioma. And also my mentor, Professor Ohata, and I also use a combined transpetrosal approach to petrocribal meningioma. Especially my modification of the minimal anterior and posterior combined transpetrosal approach is very effective procedure to resect large petrocribal meningioma. I mean, this is the petrocribal meningioma compressor brainstem. In such case, attachment of the tumor is cribus and petrous bone. In such situation, minimal anterior and combined transpetrosal approach, it can offer the very good surgical corridor from the lateral side. So we could safely resect the old tumor with preservation of neurological function. This is another case of the large petrocribal meningioma. Invade the Meckel cave and attachment is cribus and petrous bone. In such case, also the lateral corridor is very useful for resection of the tumor. This is another case of the large petrocribal meningioma. Attachment is cribus and petrous bone. So also the combined petrosal approach very useful to resect such kind of the tumor. So I think that in case of the petrocribal meningioma, combined transpetrosal or anterior petrosal approach is one of the very useful procedure to remove the tumor. But how is this case? This patient referred to us with a chief complaint of the right facial spasm. Attachment of the tumor is pure cribus, just midline tumor. Attachment of the tumor is lower cribus. In such case, how to reject this kind of the tumor is very controversial. If we choose the transcondylar or lateral suboccipital approach, we have some risk to injure the lower cranial nerves. Or if we choose the combined or anterior transpetrosal approach, we have some risk to injure the abducens nerve. But if we access the clival tumor by the endoscopic endonasal approach, we can directly access the clivus without crossing over any cranial nerves. So we can preserve the abducens nerve, facial, vestibular nerve, also the lower cranial nerves. So in this case, I access this tumor by the endoscopic endonasal transclival approach. I will show our surgical video. At first, I widely expose the clivus and drill out the entire clivus. I open the foramen magnum and also drill out the jugular tubercle. So, I drill out the all bony structure around the lower clivus, and then start the removal of tumor with the cursor. One of the large benefits of this approach is that when we start the internal decompression of tumor, we already devascularize and detach the tumor. This case, the tumor was very fibrous, but already tumor was detached and devascularized. So we could carefully perform the internal decompression by the cursor. This is a basilar artery and this is a brainstem. I carefully dissect the tumor from the brainstem and the basilar artery. And this is a hypoglossal nerve. I start to remove the tumor, ventral side of the hypoglossal nerve and the vertebral artery. And then I move to the lateral side. I start to remove the tumor around the lower cranial nerves. Using this approach, we can safely preserve the lower cranial nerve and then move to the lateral side. Now identify the abducens nerve and carefully dissect the tumor. And finally, I reach the ventral side of the 7th and 8th nerve. So now I perform the most part of the tumor. Postoperatively, I rejected out almost all part of the tumor and the brainstem was successfully decompressed. After the surgery, patients not showed any deterioration of the symptom and facial spasm disappeared. Patients can eat food just after the surgery. This is another case of the recurrent lower clivus meningioma, showing the dysphagia and gait disturbance. The attachment of the tumor is a lower clivus. So I choose the same procedure of the endoscopic endonasal transclival approach. One of the surgical tips of this approach is a wide drilling of the clivus. I completely drill out the clival bone and open the foramen magnum, and then cut the dura mater. At this time, already tumor was completely devascularized. So we start the tumor removal relatively bloodless surgical field. This is the abducens nerve. This case, abducens nerve elevated upward, but we could follow the margin very safely. And I dissect the tumor from the abducens nerve and the brainstem. Tumor was already detached, so we could safely mobilize the tumor. This is the ICA and this is the lower cranial nerves. Luckily, this tumor was not hard very soft. So we could remove the tumor piece by piece. This is a tumor compressed upon the medullary junction. So I carefully remove. This is a facial nerve. Using this approach, we can reach the medial side of the facial nerve. I carefully dissect and remove the tumor totally, and all lower cranial nerve, facial nerve, and hypoglossal nerve was preserved. In this case, we could totally dissect out the tumor, and the patient did not show any symptom, and her dysphagia and gait disturbance dramatically improved. I think this is very less invasive, effective procedure. This is another case of the lower clival meningioma. She shows dysarthria, dysphagia, and gait disturbance. But patient age is 73, very old. So I choose a very less invasive procedure. Attachment of the tumor is here, so I choose the same procedure. I carefully drill out the lower clivus and also drill out the jugular tubercle. Now I coagulate the dura mater. After the opening the dura mater, tumor already devascularized. So then I carefully dissect the tumor from the critical structure. At first, the tumor involves the ICA and abducens nerve, but tumor already detached. So we could carefully dissect the tumor from the abducens nerve and ICA. I carefully dissect the tumor with a bloodless surgical field, and then dissect the tumor from the basilar artery. In case of the clival meningioma, this approach was very effective to confirm the all tumor border. I dissect the tumor from the basilar artery and also dissect from the ICA and VA. This case, some tumor was very calcified, so I gently dissect. But of course, some calcified part attached to the perforator, so I left some tumor. But brainstem was successfully decompressed, and her symptom dramatically improved. This is another case of the entire clival meningioma. Attachment of the tumor is entire clivus. So I choose the same procedure and successfully decompress the tumor. And this is another case of the recurrent lower clival meningioma. Attachment is just clivus. So I choose the endoscopic endonasal approach. Of course, some tumor the left behind because this is a recurrent case, but brainstem was successfully decompressed without any deterioration of symptom. But when we radically remove the tumor, we usually make the large dural defect around the clivus. So I will show how to seal the dural defect around the clivus. In case of the clival meningioma, dural sealing is very important to prevent the complication. I usually put some stitch around the dura mater. Of course, watertight closure was impossible because dural defect is large. But anyway, I put some stitch to put the tension to dura mater like this. To make the knot to the deep side, our surgical technique to make the sliding knot technique is very useful. And then I insert the fat tissue to subdural layer inlay. And then I put some stitch to fix the fat tissue. After this procedure, fat tissue was fixed and sustained CSF pressure. So we can perform the water tightly dural closure like this. Even increase intracranial pressure, we prevent the CSF leakage and cover the fibrin groove, and then also cover the large mucosal flap. After this procedure, we could prevent the CSF leakage. So in case of the pure clival or lower clival meningioma, I think the endoscopic endonasal transclival approach will be very useful, less invasive approach. Thank you for attention.
Thank you, dear Goto, for that wonderful, wonderful technical job that you have shown. For whether endoscopic approaches are useful or not useful, or whether they are better or not better, only time will tell, because many of us, people in our generation, have been very familiar with dealing such cases by transcranial route. And we have not, used this endoscopic route at all for such kind of cases. Maybe in the future, these approaches will be more valid. But whatever said and done, you have showed what you have showed, and people have seen what you have showed. And I am sure this will be a new, for the new generation to look into what they like and what they would like to do. Thank you, Goto. And now I have to invite another of my very fantastic, my wonderful friend, Dr. Hongo. And Dr. Hongo is one of the leaders of neurosurgery of the world. He's one of the finest technical neurosurgeons that I have seen in my life and in my career, and that you will see for yourself when he shows his work. And he has been a legend of neurosurgery in Japan, and he has taught vascular surgery, AVM surgery, intraaxial brain tumor surgery, robotic surgery, and several things like that. And he has been after Professor Sugita. He also has a very big lineage. Professor Sugita, then the great Professor Kobayashi, and then the great Professor Hongo. And of course, now there is another great who has followed him. So Professor Hongo, without any further ado, I would like to see you in a bigger screen, and I would like to see your presentation. Professor Hongo.
Thank you very much, Professor Tu, and also thank you for Professor El-Ghandour for giving me a chance to talk this prestigious webinar. Good afternoon and good evening. Well, my topic today is selecting suitable surgical approaches for the brainstem cavernous malformation. But I'm focusing on pontine malformation. Now, this is a hospital I'm working currently after returning from Shinshu University in March 2019. I have nothing to disclose. For first, cavernous malformation, also called cavernous angioma, cavernoma, or cavernous hemangioma. This is typical histology. Well, this is the famous textbook, Humans when Neurological Surgery. Well, I'm one of the editor of vascular section. And in this textbook, there is some mention about cavernous malformations. Here's the point. In the incidence is 0.425 of the population, spontaneous and familial. There are two types, and supratentorial posterior fossa spinal cord, and no intervening neural tissue. This is a very basic point. And about 5% of the annual hemorrhage rate in brainstem. And how about such indications? Patient with epileptic seizure, it's a lesionectomy, and lobar and cerebellar lesion with hemorrhage removal, and including brainstem, deep-seated splantental lesion removal is the basic treatment concept. And what about timing of surgery? At least 5 days after hemorrhage. And really symptomatic progression requires emergency decompression. Now, the goal of the surgery is complete resection while preserving neural function and developmental venous anomalies. It is usually encountered, but it should be preserved. Well, then focusing on the brainstem today, especially on the pons. And selecting a surgical approach is very important to obtain a good surgical outcome. Is to enter the brainstem from less eloquent area from the shallowest point, and also to reach the brainstem with minimal damage to the brain parenchyma. So there is safe entry zone. Well, this is very famous paper from BNI Professor Spetzler reporting on safety is very safety entry zone to the brainstem. Regarding the pons, there are two posterior side, I mean the fourth ventricular floor and also lateral. These are called to a safe entry zone of the pons. Now here, I'd like to show several cases of pontine cavernous malformations. First, this is a 21-year-old man referred to us with repeated hemorrhage with this arterial and left hemolysis. The lesion is here. It's a large one, but seeing the serial CT scans before admission, initially the lesion was small, located ventrally, and then growing with repeated hemorrhage to the posterior side. So I decided to do surgery with from the anterior. I used an anterior petrosal approach from right side, of course. Here's the surgery. During the so-called Causius triangle. And here we can see the trigeminal nerve. And just medial lower here, I put the small incision about 3 to 4 millimeters, and then going into reaching the lesion under high magnification. And here, once the lesion is entered, the hematoma was gently evacuated, and then the lesion was gradually resected from the surrounding brain stem tissue. Now, this is the final view after resection. The incision about 3-4 millimeters. Now, here showing the post-operative MRI. And the patient, when he was referred to us, he was bedridden with severely disabled extraocular movement. And post-operatively, he can be ambulant a week later, and post-op extraocular motion improved dramatically, not completely yet. Now, this is second case, 23-year-old woman referred to us with repeated hemorrhage, showing the propria. This is a lesion. So for this patient, of course, surgical indication is no problem. And how about the approach? I chose the similar approach to the previous one, and from anterior anterolateral, using anterior petrosal approach from the left side. After removing during the petrous bone here, and then now here already the small incision was made and reach lesion and evacuated hematoma and remove the lesion. I try to see the whole surrounding 360 degrees. The lesion was deep, but under high magnification and gently maneuver, the lesion was gently resected to see the grayish glial layer to prevent the residue here after resection. Now here, here showing a postoperative MRI. Here we can see the approach glute. After surgery, the patient, a week later, she had no motor weakness. Like this. Now, how about this case? 19-year-old woman referred to us with also repeated hemorrhage with dizziness and the big one. And for this patient, the lesion extruded to the fourth ventricular floor. So for this case, I chose transverse ventricular floor approach. But the point is where to incise the fourth ventricular floor, because just beneath the fourth ventricular floor, of course, there are various critical nucleus and fibers. So I think here is the very famous paper. My senior colleague, Dr. Kyoshima, published a paper, Journal of Neurosurgery, like 1993. Here he proposed safe entry zone. There are two safe entry route, infrafacial triangle and suprafacial triangle. The point is how try to preserve facial nerve function, at least for a post-operative neurological function. And here also a very famous important paper from Professor Betranfi plotting the location of the facial nerve response during surgery. It varies, not constant. So the important thing is intraoperatively brainstem mapping and monitoring. So we did extensively to these monitoring and mapping. Mapping of the fourth ventricular forward, map the facial colliculus, and also transcranial MEP for cranial nerve. Cranial nerve, especially facial nerve monitoring throughout the procedure. This is the electrode and the activities we can get with the collaboration of anesthesiologist. And again, back to this case. So for this patient, operatively, there are various neurological symptoms. And with the help of intraoperative monitoring and mapping, like AVL, transcranial MEP, and SCP, we did this surgery. At the first, the patient was placed in prone, so-called concord position, so-called. And first, here we can see the false ventricle 4. First thing I did is to identify the facial colliculus with the brainstem mapping. And then once the facial colliculus was confirmed, put the mark, and then started to remove the lesion under facial MEP, continuous facial MEP. And once this area was detracted too much, then facial nerve function decreased, then stop handling, then some rest, and again restart the procedure. With this procedure, total resection was achieved. And here the postoperative MRI showing good resection, total resection, and neurological findings a week later improved dramatically. And a couple months later, she was a musical student, and playing the piano like this. Now, this is the last case I show, the small lesion, but the almost located purely near to the fourth ventricular floor. So I chose to transverse ventricular floor approach. And the same procedure as the previous one here. This is after resection of the lesion, about 4mm incision. Now here showing the postoperative CT, the patient showing no motor weakness and no facial palsy. Now, brainstem cavernous malformation can be favorably removed with under knowledge of brainstem anatomy, function, appropriate selection of entry point, and precise evaluation of the lesion, and electrophysiological monitoring and mapping. And my take-home message today is lesion in the ventral middle side of the pons, anterior or anterolateral approach is recommendable. And lesion even in the dorsal side of the pons, anterior or anterolateral approach is still recommendable. But lesions in the pure dorsal side of the pons, a transverse ventricular floor approach can be indicated and is rather safely applied with the help of brainstem mapping and monitoring. Thank you very much for your kind attention.
Thank you, dear Hongo. And it is a pleasure to see the hospital where you're working and the mountains behind. And it's wonderful to see and hear your lecture. So Hongo will wait for questions at the end of the session. And now I will like to introduce another young and dynamic. Oscar, how do you find these words, young and dynamic? And that is my classification of Oscar. He's from Portugal and one of the emerging powers of neurosurgery, in particular spine surgery in Europe and in the world. Oscar, please go on.
Thank you. It's a big honor for me to present among the giants that we just saw, their amazing work. I would like to congratulate Professor El-Ghandour also for the amazing educational ventures. And of course, thank Professor Guo for inviting me. He's really a role model for me. It's a wonderful surgeon, either in spine, either in brain, and this is his footsteps that I'm trying to follow. My talk is on a rather rare disease, extracranial trigeminal neurinomas. I don't have any relevant disclosures for this presentation. For the young people in the audience, these are benign tumors that are arising from perineural Schwann cells. It can occur in various trigeminal nerve locations, usually solitary and slow-growing lesions. 20 to 45% of all neurinomas occur in the head and neck, and being vagus and cervical sympathetic chain, the most common involved nerves. Extracranial trigeminal neurinomas are rare disease, and though the trigeminal nerve neurinoma constitutes the second most site for intracranial neurinoma occurrence after vestibular nerve, the literature on extracranial trigeminal neurinomas is really very, very scanty. The peak incidence is between the 4th and 5th decades of life, being more common in women. And as they are slow-growing tumors, the symptoms are related with trigeminal nerve dysfunction, decreased sensitivity of different branches associated with pain from mass effect or some other type of neurological symptoms. Preoperative preparation is very important, detailed clinical examination. The MRI with and without contrast will define the tumor location, extension, and neurovascular relationship. CT scan helps in assessing bone involvement, and in some selected cases, angiography might be necessary if there is suspicion of engulfment of the carotid artery in middle fossa tumors or vertebral artery in posterior fossa tumors. The MRI is really the gold standard for the diagnosis, virtually diagnosis of tumor, specific signs, how the tumor appears, ISO or slightly hyperintense in T1, high intensity in T2, and significant enhancement after contrast. And it allows also you to evaluate the pattern of extension. There are some useful surgical considerations. These typical lesions are free mobile with a single attachment to the nerve. As I said, preoperative diagnosis can be done based on MRI. There is no need or role for biopsy in these tumors. However, the treatment can be challenging due to critical anatomical relations and involvement of different aspects of the skull base. It's most of the time is necessary to do some sort of osteotomy to expose the tumor. And since they are well encapsulated, the excision can most of the time be easily performed. Enucleation, if possible, should be the treatment to avoid recurrence, and stripping the tumor away from nerve bundles sometimes it's not very complicated. Of course, there is always controversy, a debate between nerve preservation versus nerve sacrifice, which means recurrence versus nerve function. There is a classification based on MRI from Day and Fukushima for trigeminal neurinomas. The type A, they are in interdural space in middle fossa. The type B in posterior fossa in the subdural space. The type C, which is afflicting both middle and posterior fossa, dumbbell-shaped tumors. And finally, type D, those that arise from any extracranial division of the trigeminal nerve, and this is the topic of my talk. Of course, according to the location, different operations, and for type D, different sort of myriad of operations can be done depending on the location of the tumor. You have seen this before from Professor Suri. One case of mine, a 44-year-old female with a right face dysesthesia, neuro intact with this dumbbell-shaped neurinoma. Always interesting to do some sort of angio imaging to see the relationship with internal carotid artery, which in neurinomas it's not really a problem because the tumor is separated by a firm dural layer from the carotid artery. This was our approach in intraoperative neuromonitoring, and this was the approach and the sort of bone drilling that needs to be done as shown before. And postoperatively, 11 years follow-up, and the patient is neurologically intact, just a small, very restricted numbness on V3 area. Regarding extracranial trigeminal neurinomas, that's not much really in the literature, and the best paper I could find was by Professor Gould with 28 cases of trigeminal neurinomas with extracranial extension. And he advises a reverse skull-base approach that involves a limited transcranial extradural avenue to resect the tumor. And radical surgery is associated with good, excellent outcome and long-term tumor control. This is some of cases we have been involved. V3 tumor, an old case here from quite distal in the V3 nerve, part of the nerve, a well-defined imperintense mass on the right side between the medial and lateral pterygoid muscle along the distal on the mandibular nerve. An excess stair-step osteotomy to approach the tumor was done, exclusion of the tumor and easy removal then afterwards of the tumor. Another case here of 41 female neurinoma, also in infratemporal fossa involving mesoderm, pterygoid and temporal muscle, no erosion of the mandible. And actually what we did was a zygomatic osteotomy to access the tumor with this kind of flap, cervical fascial skin flap, from the end of the mandible to the lateral orbital rim, zygomatic osteotomy, preservation of the temporal muscles and the facial nerve. These are some postoperative images. Another case of a V3 purely extracranial neurinoma, trigeminal neurinoma. The tumor lies really medial to the mandible, very close to the temporal mandible joint on a 65-year-old female. And this was what was done was an osteotomy of the upper part of the mandible and the condyle. And these are some postoperative cases. Another case that we did recently, basically
Sim, estou vendo.
A temporal craniotomy for V2 trigeminal neurinoma. We did a very restricted temporal craniotomy and literally foraminotomy.
A lesão continua grande?
The foramen was already enlarged by the tumor, but we open it like we do a foraminotomy in the spine, and this was a complete removal of the tumor. This is the tumor, and the approach, very limited left temporal craniotomy, just to access the floor of the middle fossa, and just follow the tumor, preserving the artery. And a case here of endoscopic transnasal, 54-year-old female, solely progressive left side visual impairment, V3 aposthesia, and 6 nerve palsy with facial pain. This is a tumor, and here a different strategy was adopted, taking advantage of the big corridor made by the tumor, and an endoscopic transnasal approach was done, but fortunately some small remnants lied on the maxillary sinus. Patient nevertheless did well, recovered visual impairment, 6 nerve palsy, and trigeminal aposthesia remained. We find that there are limitations with this approach. Surgical control of critical structures is critical, and also a neurocorridor. Purely endoscopic surgery for live invasion lesions like this one requires substantial experience. So my conclusions for this very rare type of tumors, extracranial neurinomas, considering the relatively low operative morbidity and good functional outcome, complete resection should be whenever it is possible, should be the aim. With well-tailored skull-based techniques to reduce the preoperative morbidity and mortality. Gross total removal is advocated to maintain the functionality of the nerve. It's necessary. In case you can only do a subtotal, post-operative radiation can be discussed, and this was not the case in any one of our tumors. The existing classifications will help you to preoperative planning, and at least in my hands, transnasal endoscopic techniques could be regarded with caution in this kind of very kind of specific tumors. Thank you.
Thank you, dear Oscar, for that wonderful presentation on quite rare tumors, benign tumors, disciplined tumors. I had, as you have mentioned in my article, they remain confined to the dura. That is the beauty. Even if they are extracranial, the dural layer of the cranial cavity continues, and it may not be called dura, but it is the It is the child of the same membrane. And you respect the membrane, work within the membranes, and you can, sometimes these tumors can become very huge as you have shown. And they can be having mass effect and symptoms. So we have to treat them, respect the membranes, and do a tumor resection. Thank you very much, Oscar. And now we are inviting one of our another big friends, Vladimir Benes. Everybody knows this personality, this wonderful, happy man of neurosurgery, wonderful technical man, a cream of neurosurgeons, a giant of neurosurgeons, and with philosophy, with honesty, with power, and with great other admiration. I invite you, my dear Vlad, to give your presentation on a new subject, which I've not heard you before. So I'm looking forward to your presentation. Nasir, have you heard him before on this arachnoid membrane?
No, it's first time as well. I guess it's going to be very interesting talk, actually, Atul.
Yes. Okay, Vlad.
Okay, gentlemen, thank you. Nasser and Atul, thanks for invitation. It's really a great pleasure to be with you again. And I hope that I will at least entertain you if I will not give you anything new. Thanks for kind words as always. I have nothing to disclose about the arachnoid or anything else. In the skull base, or what we all are doing is mostly combination of vascular and oncology or tumors. And we actually are in two different spaces. With aneurysms, which is vascular, we are in subarachnoid space, whereas with tumors, I mean meningiomas mostly, we should stay and we are extra-arachnoid. The arachnoid is really a division between the two subspecialties of neurosurgery. See the ophthalmic aneurysm. We enter the system, the arachnoid is dissected to dissect the aneurysm, to have all the space which allows us. And we can do this all through the skull base, from one third nerve to the other third nerve, from one middle cerebral to the other middle cerebral, all the division of basilar artery, complex, carotid artery, of course. In this case, all the arachnoid is dissected free, and from one single perineal craniotomy, we can clip the aneurysm from one MCA division to the other MCA division, provided we are still within the subarachnoid space and going forward through the arachnoid walls of the skull base. On the other hand, in tuberculum cell meningioma like this one, we wouldn't like to dissect the aneurysm. We lift the arachnoid. You see the optic nerve, you see the tumor, and we are lifting the arachnoid skull base. It means in this case, this is the chiasmatic system. All the outer wall is always quite firm and nicely constructed. Let's see the video that we are not cutting through, we are just lifting. Sorry that it's so much down. So this is the arachnoid of the chiasmatic system, which is being lifted from the tumor. There is still some arachnoid left. This is the inner wall, which then is cut and again lifted from the tumor. Then the tumor is resected and arachnoid preserved. This is probably the important slide which I would like to show you. This is the typical olfactory groove. Meningioma, the both tumors are exactly the same size, exactly the same location. The difference is that in this case, we have the edema in one frontal lobe only. In this case, the edema is bilateral. In this case, the anterior cerebral artery is shifted to the side. In this case, the anterior cerebral arteries are in the midline. What does it mean? That in the case on the left frontal lobe, including the olfactory nerve, is covered by 3 layers of arachnoid, and thus you can easily dissect and you will preserve not only the frontal lobe, but also the olfactory nerve. Just the opposite in the case on the right-hand side, then the frontal lobes, both olfactory nerves are covered by one single layer of arachnoid only. And this is, let's say, the philosophy of everything what I'm going to tell you. This is what it looks like. This is a small olfactory groove meningioma, which is now being resected. We are at the end of resection. You see that it's already the origin in the olfactory groove, and the left olfactory nerve is nicely preserved along with the arachnoid of the olfactory system. And thus we can preserve the smell for the patient. This is what we have published, and we were able in our cases to preserve this function of the first nerve if in more than half of the patients. There were, of course, subgroups. Anatomy of arachnoid system was not that much studied. These are the rotten images, which are excellent and perfect as always, and you can get a good orientation in general way in the arachnoid. Then there was Kuruc, who studied the arachnoid, the systems by the use of the endoscope, and these images are excellent. On the other hand, it's there are two articles and they are rather difficult to read, and you need to jump from text to images back and forth, and it's very, very sophisticated and nice. These are the dissections we are doing now. We have a specific technique that we soften the skull base, then we resect the skull and we get the side from below, and these are the images we are getting. You see the Lillienquist membrane, the posterior fossa systems, and you already you see the systems are not that well defined. The really true wall is the Lillienquist membrane separating the supra and infradentorial space. Rather well, the carotid system is defined. Otherwise, it's not that easy, as I will show you very soon. This is just, we published the technique how to dissect the skull base. You may like to read it and you may like to repeat it in your lab, because these are the images you are getting. This is without injection. And here we are in the carotid system, here we are in the ambient system. This is the third nerve. And you see that the arachnoid layers do not really form a wall. They are more like trabecules, like sustentacles, just like not really firm wall, which wouldn't allow the CSF to flow. It's really constructed in a way that the flow of CSF is free, thus not firm wall apart from the outer wall. All the time in the skull base, we are just on a very, very tiny area. This is the anterior communicating complex. It means that here we are in chiasmatic system, going back to the anterior spinal system. The whole circle of the skull base is only 35 millimeter in diameter. So it's really tiny space and very, very difficult anatomy. Definitely, this is the most difficult anatomy of the human body, since although the cavernous sinus is involved here. Here are some dissections. You see the carotid artery, you see the optic nerve. We are looking from below. Don't forget, again, the Lillienquist membrane as a very firm structure. This is the posterior fossa. This is the fifth nerve, which is very nicely covered by the outer membrane of the cerebropontine system, not so more proximally, getting to the petrous apex, which used to be here. There, the wall against the brainstem already is not that firm, and it's probably the reason why the petroclival meningioma sometimes must a piece be left behind when it affects the brainstem. This is the sixth nerve, very nicely seen, the Dorellos canal as it enters. So what we need in meningioma surgery is planning the approach with advanced knowledge of systems and expected arachnoid layers, where you will hit, where you will have your border of dissection. Exact tumor origin should be defined as good as possible. It would be angiography, but we do not do angiographies anymore. Neither of us does that. So it's T2 images on MR, which are the surgical images, and where you quite frequently pinpoint the tumor origin. Then defining in which system we are going to do our job, which means that we know which structures are there, like the cerebropontine system with 7th, 8th, and 5th, and 6th nerves, and so on and so on. Each system has the content. So aneurysm surgery is about the arachnoid membranes, but the arachnoid do not heal it. It looks like that with the ophthalmic aneurysm, the optic canal and carotid are opened, and you see the arachnoid the carotid system as it's split on the aneurysm sac and must be dissected. You see the optic nerve, it's really splayed over the aneurysm wall, and just willing to decompress the optic nerve, we need really to dissect the aneurysm from the aneurysm, not to harm the tiny vessels which are within these layers and which feed the optic nerve. I believe that this is enough. Let's see what it looks like after the surgery. The optic nerve regained its normal position, and surprisingly, the vision improved immediately after surgery, despite this appearance of the optic nerve at the beginning of the canal. The opposite is true with meningioma surgery. Do not cut the arachnoid unless necessary. As you cut in aneurysm surgery, you wouldn't like to cut the arachnoid in meningioma surgery. This is a simple CP angle. And you see that at the end of surgery, the dorsal wall of the cerebellopontine system is preserved. Just the 7th, 8th, and 5th are still shiny and covered by the arachnoid, unharmed and untouched. This is the petrous apex tumor, and we were only in prepontine and cerebellopontine, or those systems which were not open. You see that the arachnoid is still preserved after the tumor resection. Another one which already is located within the cerebellopontine system, and you see that the nerves are not anymore shiny but preserved, of course, but in this case only the nerves are covered by its own arachnoid only. You cannot be using the arachnoid of the cerebellopontine system as the wall, as the plane of resection. The tentorial meningioma, which will only be located in the ambient system. This is the anatomical image. The tumor has its origin somewhere here, and the ambient system means only the fourth nerve, nothing else. And this is after surgery. The fourth nerve is hidden here underneath the tentorium, and you see that all the other system walls are still preserved untouched, thus ensuring that the structures within these systems are not harmed. The CC junction meningioma, the 11th, the 12th, which is cerebellomedullary system, which is opened and which is the only system where the tumor grows, and the lateral side of the bones. Coming back to tuberculum cell meningiomas, you see that the chiasmatic system is the only one which is affected, and all the structures are still covered by the arachnoid. Small anterior clinoid meningioma, extradural clinoidectomy first, then only the chiasmatic and carotid system are making the wall of the tumor, which is actually outside on the small tiny part of carotid artery, which is not covered by the arachnoid. Here is where the tumor used to be, no other structures involved. Another tumor of the anterior clinoid, you see the encased carotid. But here is a little black line coming to the carotid artery, and this is the arachnoid which is squeezed between the lobules of the tumor, and this is the beginning, the chiasmatic system. Then after the resection, you see the link with membrane, posterior clinoid, and this is what was really affected. This was dissected just to clean the surgical field, but you see the line of arachnoid of Lillienquist membrane. Here is the carotid artery, and here is the second nerve. Here used to be the anterior clinoid, and without passing the arachnoid layer deeper, you may be able to resect the whole tumor like that one. Coming to the part which was already discussed quite frequently by Japanese colleagues, coming to petroclival region, you have ambient system, crural system, intramural system, of course, cerebellopontine system, and this is probably the reason why I love supracerebral infratentorial approach to reach all these systems, and you get higher up to the midline, where is the quadrigeminal, and one shouldn't forget that velum interpositum is also in a way a system. So here is a tumor of cavernous sinus reaching the chiasmatic region from posterior, being in the CP angle. I resect these tumors by supra-infra approach. The first step is CP angle along the closer sinus, then cutting the tentorium, and then going for subtemporal part and for the part which is in the interpeduncular system. So first you see 7th, 8th, ICA, and 5th. Then the 5th and 6th nerve. 6th nerve I always seek actively because the loss of the 6th nerve function is a very, very serious morbidity. Then coming forward, we are passing from cerebellopontine to ambient system. This is the 4th nerve, and the tumor penetrated these walls, and it's anterior to that. And after the resection of interpeduncular part, you see the opposite side. This is the opposite side P2, opposite side optical tract, the pituitary stalk and clinoid process. This is the ipsilateral side where we have again posterior cerebral artery, again the 3rd nerve, and superior cerebral artery underneath the 3rd nerve. You will see that the resection was terminated, or the anterior wall of resection is the Lillienquist membrane, the shiny structure here. This is the basilar artery, superior cerebral and posterior cerebral artery. And this is the whole approach. Here is the cerebellum, here is the tentorium, and here used to be the tumor. This is after we do not enter cavernous sinus for meningioma, we just leave it behind for observation, and if need, then we use the radiosurgical means to control these tumors. The potential of the supra-infra approach was published by us a few months ago, and this is the last case I would like to show you, because this is the meningioma which really entered even the velum interpositum, which is quite rare and infrequent occurrence. This is again the supra-infra approach, and the systems involved is the quadrigeminal ambience, its dorsal part, and velum interpositum, which is above. So this is what it looks like coming from supra-infra on the right-hand side. I never ever use the bilateral approach. I think the tentorium to get the subtemporal part of the tumor, which is on the right side. You already see the base of the temporal lobe. This is just a helpful trick when you cut the tentorium to put a stitch to the tentorium, and you get another 2 or 3 millimeters of space, which gives you some more maneuverability, which is always called for in these formidable lesions. And then going again intra-arachnoid, you see the arachnoid of the tentorial notch above the tumor. This is the lobule which is underneath the temporal lobe. Here already the structure is the corpus callosum, getting the anterior and more medial part of the tumor, which was really growing rather invasively. The vessels were inside. And this is that strange thing that the tumor is growing into the velum interpositum. Here is the anterior arachnoid of the quadrigeminal system, which I cut just to get through. And this is the piece of the tumor which is located within the velum interpositum. When this is resected, you then again, you see the vessels, how firmly they were attached and how dense the arachnoid here is. Now we are underneath the tumor, the structures here again, quadrigeminal system, and we have the quadrigeminal plate in our side. And the last to be resected was the piece of the tumor which was located on the left side. This is the Rosenthal vein on the left side. And this is just by the end, you see all the vessels which were rather firmly attached to the tumor. This is the opening of the third ventricle. And this is the end of surgery. So let's finish it. This is post-op image. And this is the last slide I have for you. And this is what my friend Imad Kanan is always telling us, that arachnoid is a friend, definitely. Arachnoid is a wall. Arachnoid is your point of orientation, and don't tear it, don't cut it, because arachnoid belongs to the patient. Thank you for your attention, gentlemen.
Thank you, my dear arachnoid. When I say arachnoid means friend, my dear. Thank you, my dear friend, for that wonderful presentation, wonderful information, and a new thought process. And I'm sure many of us would have loved to hear what you have said. So Nasir, over to you. Nasir?
Atul, I don't know. I think we are far beyond the schedule. I suggest to proceed with the scientific session and make discussion at the end of the webinar. What do you think?
I agree with you. I agree with you.
Okay.
So the next presentation is mine. And I have to tell you one thing that, just a minute, please, that John Bennett, who is the founder of Neurosurgical TV, is trying a new kind of a system where he is going to, after my lecture, he's going to give some kind of, you can make presentation, you can ask me questions on a separate Zoom. So that is what something he has done. I'm not sure exactly how it works, but maybe he can explain to us after we are done. So you remember that what I've said, like my questions can be asked on a separate Zoom. So how it has to be done, let us see, he will tell us. And this he's trying for the first time. So I'm going to give you a presentation of a different kind. You know, you have heard me talking on craniovertebral junction. You have heard me talking on cavernous sinus. You have heard me talking on spine. But I want to give you a concept on gliomas, which is a subject of my interest for last 10 years, or at least for whole life of neurosurgery, but more for last 10 years. So the cover slide of that, just a minute, sorry for that. So I'm introducing a new concept and surgical strategy for gliomas. So that is my title. We have, in our entire neurosurgery, we have learned how to operate on high-grade tumors, and more radical a surgeon can remove the high-grade tumor, more experienced he is. That was considered to be the thought. Low-grade gliomas have been considered as diffuse, invasive, infiltrative, and here what exactly should be done has been a controversy, but more recently the controversy has been actually sorted out, and we talk of radical resection, and that has several advantages. As regards the growth of a glioma, not many articles are there. People have talked about growth of gliomas along the vascular structures, along the territory of MCA or ACA, like they are having a wedge shape. So that is this is from Yasargil paper. Other than that, not much has been written about how the gliomas, where the gliomas arise and how they expand. So there have been some phenomenal contributors to surgery of low-grade gliomas. Mitch Berger is the leader. And Mitch Berger has talked about high-grade gliomas, low-grade gliomas. So if you really ask me, my concept is now that you should do radical resection, try to do total resection of low-grade gliomas, and try to be a little bit conservative in high-grade gliomas. So that is my current concept. Conservative does not mean biopsy or small resection, radical resection, but a little bit more conservative. We also have heard several times about our dear scientist, Dr. Defoe, who has been a proponent of low-grade glioma surgery. So essentially, low-grade glioma surgery is, my understanding is, it relieves symptoms. It reduces tumor burden. It improves the quality of life. It improves definitely quality of life, longevity of life, and also it delays the malignant transformation of the tumor. So these are the advantages of low-grade glioma surgery. And a lot of technology has developed to affect this low-grade glioma surgery, neuromonitoring, intraoperative monitoring, various dyes and drugs to evaluate the extent of resection. But most important in my understanding is the anatomy of white fibers. And anatomy of white fibers, which was never taught even when I was undergraduate or graduate in neurosurgery. But we now know that white fibers form the foundation of the brain and they have tremendous functions. And the more important thing which I have to give a message, that gliomas arise from white fibers. Gliomas arise from a named white fibers and grows along a named white fiber. So this sentence you must remember. Arises from a white fiber tract and grows along and displaces the adjoining tracts. So these are short arcuate fibers. We have all seen this. So this is the title. Gliomas are confined tumors. They are confined to a named white fiber tracts. They are like meningiomas, which are confined tumors. They have a pseudocapsule kind of thing around it. And you can get a plane of dissection around that glioma to do a resection. And that will lead to an en masse kind of resection. So this is a new concept and it can just be a revolution in the understanding of gliomas, in the surgery of gliomas. So is en masse tumor resection a safe surgical strategy for low-grade gliomas, which we have always talked as diffuse, infiltrative, and things like that? My answer after my experience over a few years is that yes, it is possible. Yes, it is safe. And yes, it leads to radical tumor resection. So white fiber dissection has been studied in my department in various articles that you must have read. And this is one of these articles, white fibers of Pape circuit, brainstem anatomy we have studied with various of my colleagues that you are seeing, including my daughter is here. And this is one of the most phenomenal articles that you will see ever. The dissection of brainstem has never been done in this fashion ever in the history of neurosurgery. So this is my big power in my department. As regards white fibers, we divided into 5 groups, white fibers, horizontal groups and the vertical group. So superficial group is the short association or the arcuate fibers. Middle group is the SLF, arcuate fascicle, inferior longitudinal fascicle, middle longitudinal fascicle, uncinate, IFOP. Deep group are the paraventricular group like Fornis striaterminal, central group like corpus callosum, and things like that. Vertical group is the projection fiber. So this is the classification of white fibers that we did. And in our article, we mentioned about the various functions which were generally ignored in the surgery of brain tumors, and these are the functions. And we have studied how the anatomical extension of glioma is based on white fiber tracts, and we have proposed this classification. More important is gliomas arise in a white fiber tract, grows along the white fiber tract, displaces the adjoining tracts, and you can get a plane of dissection around those tumors. So we divided gliomas into 2 groups on short arcuate fibers, focal group or localized group, diffuse group along the commissural fibers like corpus callosum fibers. These are diffuse groups. So this is the classification that we introduced, but they are along a fiber tract. And you can see all your gliomas, you will find them a pattern of extension. So this is in the superior frontal gyrus. You see how the superior longitudinal fascicle, the projection fibers are displaced by this tumor. They are not encased. And if there is a deficit of motor fibers, this is due to pressure and not due to invasion. And you can develop a plane of dissection here to do a good radical resection. So this is in the parietal postcentral gyrus. You see, it displaces the projection fibers. It does not invade into it. It destroys, it gives functional loss due to pressure, not due to destruction. And it is a well-defined tumor. And on the basis of this, I will show you how we design surgery. So now this is a very common location, dangerous areas, supplementary motor area. You can see the relationship with the projection fibers, the displacement of projection fibers. And I will show you almost an unedited surgery of this case. So Dura has been opened. I used to put neuromonitoring at this point of time. I identify with navigation and with ultrasound. Now you carefully see in this dangerous area where there is motor strip, how I am dissecting the tumor with this special suction. This is not suction. I am identifying the tumor from the adjoining brain, and you see how well defined the tumor is, like a nodule. And with my increasing experience, you see this suction, you can identify, you see how I'm holding the tumor and displacing the tumor and designing a plane of dissection. And I must tell you, this is not an edited tape. This is completely as it is going on in the operation. And you can see in this dangerous looking area, how I am getting a plane of dissection around the tumor. And you can also see by the basis of color, by the basis of difference between normal brain and the tumor, how I'm developing plane with this special kind of instrument that I'm holding in my right hand. And with the tip of my suction, I'm developing a plane of dissection on the basis of consistency. And if you have realized that in not even 1 minute or 2 minutes, I have dissected this tumor without a single coagulation. This is not an edited tape. Please remember, maybe a little bit edited here and there, but not much. And you can see that this tumor in a dangerous looking area, you know, if you go on doing mapping and all those things, you can go on for 5 hours, 6 hours, maybe 10 hours. But this is a 3-minute operation, and which is completely on the basis of understanding that you can develop. You see, I'm not showing you some technical mastery or showing subarachnoid dissection, but I'm giving you a concept. I'm giving you a concept that these tumors, you see how this lip of the tumor is going inside the brain, and this special instrument which I have in my right hand, it is the suction, but I don't call it suction. I call it a magic tool. And I am actually not only sucking, but I'm developing a plane of dissection around the tumor. And you see how I'm removing the tumor from a very critical area of the brain. So this is en masse tumor resection. And you see, once you get this en masse tumor, the resection is quite radical, and resection is quite complete, and resection is quite safe. Now I will show you some other tumors in critical areas of the brain. You see, this is the tumor, and this is the functional mapping, fiber track, and you see this tumor, and you see the size of the tumor. Please enjoy this surgery. And I have to only tell you that this surgery is not an edited version. I have moved a little bit from here, but this is not an edited tape. So such a large tumor, such a tumor in relative, it is not as bad an area as the earlier case was, but you see how I'm making a plane of dissection, and there is hardly any coagulation. Little bit editing is there, but very, very minimum, if at all, no editing. And you see how I'm developing with the suction. This is not sucking the brain, you must remember. This is holding the tumor in one hand, and I'm sure this is not, of course, subarachnoid dissection where I can show you the arteries and beautiful nerves. And this is a glioma surgery. This is a glioma of low-grade infiltrative glioma. And this is a radical tumor resection that you are seeing. And you are seeing how I'm designing this surgery and how I'm going further in this surgery. A little bit I will edit here just for in the interest of time. And basically the whole operation that you are seeing here is exactly 5 minutes. And you can imagine such a large tumor, and such a tumor which is quite controversial in the literature. If somebody can remove in 5 minutes, you can imagine the concept. I'm not talking about time. I'm not talking about anything, but I am talking about a concept that you can remove these tumors like you remove a nodule of a Cushing disease, like a pseudo tumor. There you can develop a plane of dissection. And in that plane of dissection, if you can develop, then you can avoid all the monitoring. You can avoid awake craniotomy. You can avoid functional mapping. You can avoid connectomes, which are supposed to be around the tumor. Connectome understanding is the latest craze in surgery of low-grade gliomas and high-grade gliomas. So my other concept is even high-grade gliomas have a well-defined plane of dissection. And both low-grade gliomas and high-grade gliomas are similar in their configuration. They are different only by the pattern of their multiplication. And you see how I am developing a plane of dissection, little bit not such dangerous area, but a plane from normal and abnormal. This, of course, will depend on your experience in how much you are doing and how much you have handled these kind of tumors. But I can tell you from my experience, this plane can be developed and this plane can be safe, and this can, you can do a radical surgery if you. So this is the complete tumor resection. You see how, and within 5 minutes of operation, I have already shown you in my presentation 2 complete operations of low-grade gliomas. And this is another tumor. You can see the location in the region of motor strip, and you can see the relationship with various fibers. And these are dangerous tumors. You can create hemiplegia. And now you see, I will show you a complete operation without any kind of, basically I use navigation. I use ultrasound in the initial part of the operation, and then I go ahead and do this dissection, which you will see, and you will see the entire surgery in exactly 5 minutes or maybe less than 5 minutes. So this little bit, whatever editing I am doing here is on my own screen, but this tape itself is not an edited tape. And you see how I am developing a plane of dissection between normal and abnormal. So that is possible. That is possible, and you can imagine this tumor. This is actually the motor strip. You can, if you damage the motor strip and create hemiplegia, you can, of course, you can you can have a disaster at hand. You cannot say I have removed en masse and totally and all those and create hemiplegia. You have to be confident. You have to be sure. You have to be definite that this is the strategy and this is the way you have to remove this tumor. So this is, you see how I'm removing the tumor from most critical area of the brain. You just, I will little bit edit here for the sake of time, but you see the dissection. My suction is not sucking the brain. My suction is just sucking the blood and developing a plane of dissection. It is my, on the tip of my suction, my eyes are there. By the feeling, by the consistency, by the vascularity, I can identify the plane from normal, from abnormal. And then I rub it, almost like dissect it, like a blunt dissection. You cannot have sharp dissection. This is not arachnoid plane. This is you need a dissection in a plane between the tumor and the normal brain, and then you have to go ahead and remove this tumor. And I have to tell you, white fiber, these tumors arise from a tract, they displace the adjoining tract, and you see in the most critical area of the brain, this is the motor strip. We have actually seen exactly, and this is the post-operative. During Corona times, I had done this dissection. So is en masse tumor resection a safe? Absolutely yes, in any part of the brain. And these connectomes are important, but these connectomes are also displaced. Functional structures are displaced by the tumor. So in most critical areas of the motor strip, you can do such a dissection, a safe dissection. And you see this was, of course, in a little bit better area, but this is completely removed. This is another tumor in similar kind of area. So this is the tumor. You can imagine the relationship, and this is radical tumor, and we have studied the entire specimen from this part to this part. There is tumor and nothing but tumor in this. I will like to little bit show you this case also. So you remember I have shown you complete 3 operations in my talk, and this is the 4th operation, which I will little bit edit in the sake of time. And you see how I'm developing a plane of dissection in this critical area of the brain. So you can remove, and very minimum or no coagulation at all. There is no coagulation. I don't believe in this process of coagulation, unnecessary burning and charring the brain, and unnecessary burning and charring the tumor. You develop, you identify the tumor, you identify the plane of dissection, and you remove these difficult tumors in a beautiful fashion. So this is the tumor resection, which has been done in a very fantastic manner. This is another tumor, and I don't want to show this complete. You see this color, by the color, you touch this, this is different. By the color you can identify, by the consistency, by the vascularity. I will just show you a little bit of this case also, because you see how I'm removing this tumor in a circumferential plane around, and I know for sure that adjoining tracts are safe and dissection is possible and safely possible. So this is another tumor that you are seeing which has been removed. And this is the tumor. You see how clean it can remove, and the entire tumor has been studied, and there is no tumor. There is nothing but tumor in this. So this is another tumor which has been removed en masse. This is, you can see this tumor and the location, and these kind of tumors in the parahippocampal gyrus. Of course, I have done inferior temporal gyrus approach and I have removed this tumor. Essentially, you see, essentially, this has been cut by the pathologist, but essentially en masse. And it pushes the vessels, it pushes the arachnoid, pushes the pia, and you only if you can develop a plane. So this is high-grade gliomas in the orbital cortex. High-grade also have a well-defined plane of dissection. And they are also from white fiber tract, and they are going along the white fiber tract. This understanding is a revolution in glioma surgery. So this is another high-grade glioma which has been essentially removed en masse. Insular tumors, of course, insular surgery is a special surgery, and many of you on the screen are masters of this. And I have to tell you, most important thing in insular surgery is to know the anatomy of tract, know the anatomy of uncinate fasciculus, about the IFOF, know the anatomy of the gyra and rectus in this area. And you can, and the relationship with the various tracts, with the important insular areas and caudate head and putamen and all those things are critically external capsule and claustrum. And you have to know that you can develop a plane of dissection. So this is one tumor in the region of speech area, Broca's area. Now I will like to show you this patient. We tried to do awake, but he was completely not possible. So you please see this video where I will show you in this critical area of the brain how I am developing a plane of dissection and how I am saving the blood vessels. Little bit I will edit, and you see this tumor. This is tumor and this is normal brain. From the color you can identify, from the consistency you can identify. And in this speech area, a dangerous area as we know, we cannot make him aphasic and say, yeah, we have removed the tumor. Then biopsy could have been better. But now you see, if we, little bit I will edit here, and you see how I am getting the plane of dissection between the vessels. And for insular tumor, needless to say that preserving of the vessels is the most critical part. If you damage one vessel in the insular region, you can create a devastating complication. Even the veins you have to save if possible, but veins of course can be taken with little bit of impunity. So here, as you have seen, I have little bit edited, but now you see how I'm developing a plane of dissection in this Broca's area. You see the tumor dissection? You see how I've got a nodule? It is like a meningioma being removed from the adjoining arachnoid. This tumor, and you can see the preoperative image like a low-grade diffuse. So I'm trying to tell you that these are confined tumors. These are like meningiomas. These can be removed completely. These can be removed without any major monitoring technique. These can be removed en masse, and this should be, and they displace the adjoining critical structures. They do not involve the adjoining structures by destruction, but by pressure. So these, you see this tumor being removed, and I have saved all the blood vessels in the region which are most important. As any single blood vessel you damage, you can actually just make hemiplegia. So this is the dissection that I am showing you, a different dissection. This is not a beautiful dissection that I will show you when I am showing you basilar artery aneurysm or some meningioma here and there. This is a different, this is glioma surgery. But I am giving you a concept that glioma surgery can be done like this. It can be done effectively, it can be done beautifully, and it can be done radically in the interest of the patient. and more important, safely. By this kind of, more important is you have to save all the blood vessels. So this is the patient and he's talking post-operatively without any speech deficit. So I don't want to, so now I don't want to go in this, and this is the tumor resection. Needless to say that anatomy of tracts is so important. This is another in insular region. I cannot show you more than 10 operations in 15 minutes. Nasir will not be too happy, but I have shown you at least 5 full glioma surgery in my time allotted to me. And you see this insular tumor radically resected. This tumor, uncinate fiber tumor, beautiful uncinate. You can come around the tumor and do this resection. So you have to know the anatomy of fiber tracts. You have to know the anatomy of the region. And if you do not know, you cannot do, you should not do. And if you do, it is not right. You can be very nasty. Don't do if you don't have anatomy. Corpus callosal glioma, Nasir, is another. Corpus callosum itself is a magical structure. It takes care of the whole brain. I never knew it till the people in my department did the dissection and showed me. And it completely circumference, it goes to all parts of the brain. And that corpus callosum, how the tumor involves the fiber of corpus callosum and how it goes is a beauty. It remains within the tracts. It goes along the cingulum and along the fiber tracts of the corpus callosum. This is the extension of corpus callosum. And this, you see this beauty of corpus callosum, which we published paper, how forceps major, forceps minor, how it goes to the motor tract, how it circumferentially covers the ventricle and all those things. Beautiful. You must read this article from my department and how it takes care. We never know where to take a corpus callosum incision, how to avoid motor fibers. How the tumor goes along these tracts. We have to just read this article, and this is a beautiful article from my department. So you see how the tumor goes. It displaces the structures. It displaces the projection fibers, and you can remove it beautifully circumferentially. So we have done several corpus callosal tumors, and just I want to show you a new approach that we had described some 15 years ago, orbital cortical approach for ventricular tumor. So recently from my department, they have studied the anatomy and surgical experience with this orbital cortical approach. For such tumors, you cannot go interhemispheric, you can come from this cortex, and how to save the uncinate fibers, how to save the IFOF, how to save the fibers of the anterior commissure are very important, and you can do a very radical resection, essentially en masse for even such tumors. So these are the various targets for orbital cortical approach. This is the surgical strategy. These kinds of tumor which are high grade or low grade, I don't consider. High grade are also older brother of low grade. It remains within the confines of white fiber. So this is what I have to give this message. And Pape circuit is another beautiful thing that from my department has been studied, and nobody in the world has ever dissected Pape circuit out of the brain like this. So anatomy is the key, understanding is the concept, and performing is the art. So please know all these three things if you have to do complex brain tumor surgery. So now what I'm going to do, Nasir, I'm going to get out of Zoom, and John Bennett is going to give another platform for those whilst the other program is going on. You please conduct the other program, and there will be a special window, I believe, for the questions to ask me if anybody wants to ask questions. Okay, Nasir?
Yes, it's very good. Let me first of all thank Atul Goel. That's an amazing presentation. It's a fascinating talk. Atul Goel is a great speaker, great innovator. He changed many concepts in neurosurgery. My friend, you are doing a revolution not only in glioma surgery, but in all neurosurgery. Thank you very much for this great talk.
Thank you very much, Nasir, for your wonderful comments. I thank you very much. So I will just get out of here.
Hassan IT.
Yes, doctor. Yes, doctor.
I think Professor Atul Guel is not longer joining. I don't know. He is disconnected. And what John Bennett is trying to do now? Shall we proceed or wait?
No, I think we should proceed. I think what John is doing is interviewing Atul, and
okay.
Atul is giving is answering questions on a separate platform, so we can go ahead
okay.
with the program.
Okay, thank you very much. Now I have the pleasure to introduce our next speaker, Professor Albert Sofyanov. Professor Sofyanov is a medical director and founder of the Federal Center of Neurosurgery in Russia, and he is chairman of the Department of Neurosurgery at the First State Medical University in Moscow, Russia. Thank you for joining, Albert. Albert, would you unmute your mic, please?
Yeah. Okay. Okay, moment. Показать демонстрацию экрана. Okay. Possible to see?
Yes, it's good.
Okay. At first, I want to say thank you very much for inviting me, Professor El-Ghandour and Professor Guel. It's a big honor for me to join big names and the big team. And in this presentation, I want to speak about another side of the tumor surgery. I want to speak our personal knowledge about the endoscopic treatment of intraventricular tumors. I am from Tyumen, very nice city. In this Tyumen, our government created for us a new high technology hospital. This hospital the name is Federal Center of Neurosurgery, is especially only for neurosurgery. To our topics, why endoscopic treatment of intraventricular tumor is possible? Because we have some conditions. First one, we have a large cavities, ventricles. And second, very important point is the transparent medium we have as a cerebrospinal fluid. And another is a lot of modern endoscopic equipment now we have, and all these conditions give us possibility to have to condition for endoscopic treatment of intraventricular tumors. So we have now experienced more than 100 patients with this endoscopic technique with good follow-up, more than 5-6 years. We started in 1999. Endoscopic procedure includes some options like endoscopic biopsy, endoscopic resection, endoscopic removal of the tumor. Here of me is good, Professor Nasser?
It's very good. It's very good. Yes.
Okay. And the tumor localization also, colloids of third ventricle, lateral ventricle, and so on, third ventricle, fourth ventricle, and so on. For this kind of surgery, we must have a good equipment, especially endoscopic equipment. And you see my operation room for this kind of surgery. And the most important, as you see, you must have a very good screen. And you have as an example of this screen. This is a 4K screen, because the image quality is very important, just to differentiate the color and so on during the tumor surgery. A lot of endoscopic equipment the surgeon must have: rigid, semi-rigid, flexible endoscope to this kind of surgery. And we also use space endoscope, channel endoscope, but mainly now I use and prefer the Storz company and Professor Schroeder's endoscope. The name of endoscope is LOTA. Also, you must have lot of neuroscopic some instruments like scissors, dissectors, calculations, and so on. And very beautiful now, we have the videoscope possibility. Videoscope is a new technology. This is not flexible endoscope. This is a videoscope, and the tip for the visualization is on the camera, a special digital camera on the tip, localized on the tip of the videoscope. But the quality of the image now is compared like a rigid endoscope. So it's a very perspective also in this kind of treatment. Also, most important for this kind of surgery is neuronavigation. So a lot of neuronavigation. We prefer some brain lab navigation, but possible also some electronics, magnetic, and so on. Another new perspective in this kind of surgery we open by use the laser. In our place, we have a new tool, thulium laser with improved conditions for the coagulation, for hemostasis, and so on. You see on the slide. And you see how we use the laser. We put in the laser probe inside of the working canal, also endoscope like a lot, or maybe a very thin endoscope like this, and then make operation. Also, sometimes it's very useful, some hybrid ICT room, especially in difficult case with difficult orientation, and with possibility to make a CT scan and update neuronavigation data during operation. It's also sometimes very important. Also very important thing is how you fix your endoscope. So most popular is two techniques, the freehand technique, and another one is a fixed technique. In our place, possible to use some kind of the fixation, like a Layla, for example, mechanical detector, but I prefer the pneumatic holder like a Mitaka you see on this slide. And also a very new possibility for this kind of surgery is very important. I believe is the future for this kind of surgery is the possibility to use 3D endoscope. In our Federal Center of Neurosurgery, we use 3D endoscope for this kind of surgery. Video sense. This ventricular scope has a working canal. And then 0 and 30 degrees possibility to view. You see this kind of endoscope. This very new tool with enough 3D HD image. So why modern neuroendoscopy like a pirate? You know, this is one hand and one eyes. But we to perform this kind of operation safely, effectively, radically, you must improve our technology. So I try to introduce 3D neuroendoscopy, and now surgeons have two eyes, binocular vision, and for bimanual manipulation, for example, easy bimanual manipulation, I introduce multi-portal approach. So A neuroendoscopy technology in our center is bimanual binocular neuroendoscopy, like a samurai, not like a pirate, but like a samurai now. This is our perspective. Again, very important with knowledge about the landmarks and anatomical nuances in the target point of operation. For example, lateral ventricle, third ventricle, fourth ventricle, and so on. In this slide, you see some anatomical dissection because I have very good cadaver lab in my place. So we study intensively this anatomy before we start this kind of surgery. You see some examples, for example, anterior landmark of the anterior wall of the third ventricle, for example, and so on. Also, very interesting, we use just understanding anatomy before in personal patients some reality just to investigate the possibility of removing. Also, we use the possible some special models. We developed some special 3D printing model you see on the screen like this, and it's possible to simulate any kind of operation and a special operation. For example, you see the CT model with the tumor, for example. This is the data from the patient, and we after we receive the data, the ICOM data, for example, we print this model and train before surgery. Also improve our skills. We have some options about transventricular tumor surgery. So first and most is our goal is the total pure endoscopic removal. Another possibility option is partial pure endoscopic removal. Also, we have a possibility to biopsy when endoscopic assisted removal, and one of the most popular common is the management of the secondary hydrocephalus. It depends on the anatomical features of the ventricle, localization, lesion, size of ventricles, vascular supply, and most important, in my opinion, is the experience of surgical teams. We have some approaches. It depends from the tumor localization. So we have possibility from anterior transventricular approach, middle transventricular approach, and posterior transventricular approach from occipital horn. Also, for biportal or multiportal approach is very important, the entry point. So in this slide, you see the possibility of the entry points just for middle, posterior, anterior approaches. Also, I introduced some classification of approaches, endoscopic approach for the brain tumor surgery. It depends from localization of the approach, so it depends from monoportal, multiportal. Multiportal is depends and must be biventricle or both sides, or monoventricle through the ventricle on the one side, but must be biportal, triportal, and so on. Also, very important is the type of port, what you use for this kind of surgery. I divide the endoscopic port, pure endoscopic port, and endoscope assistant port by possibility of use endoscope or exoscope, for example. So endoscopic pure is for gap, LOTA, mini LOTA, pilloway, and so on, like this. But for assistant, for exoscope, endoscope assistant port, we use usually tubular retractor, transparent tubular retractor. And also possible to combinate of port. So we use port only for visualization. We use port only for work instrument, for example, or we combine with both possibility. So this is some examples of the monoportal approach that you see, navigated endoscope sheet, or multiportal approach. You see two ports. One is for visualization, one is for instrument, for example. This is a typical room for the biportal approach. And this is incision, localization of the entry point, for example, incision of the skin. If a child surgery is commonly we use fontanelle approach, transfontanelle. And some examples of the our possibilities. Because it's a little bit restricting time, some videos I escape. So endoscopic monoportal dissection or biopsy possibility. You see some example of neurofibromatosis, 3 years male, and the tumor block Monroe. So we put endoscope inside the lateral ventricle and see the tumor inside. A good landmark like Holy Place papilloma. And you see nucleus septum pellucidum. And first, because we don't know what's possible to remove the tumor and deblocked of the Monroe, so we create the septostomy. And the size of the septostomy must be enough and not closed in the future. With a technique, how a technique of septostomy you see on the screen. And then after septomy is done, we try to dissect the tumor from the Monroe. We use the scissors, not only like scissors, but for dissection also. So it's multi-purpose instrument for us. This is a very careful, very precise dissection, and we try to open the Monroe. You see, dissect, not only cut. You see the vessels, and we part piece by piece. We remove the tumor. And now we remove the tumor partially and open the Monroe. You see the fornix, and now we see Monroe is open, and we have a biopsy. The goal achieved. This is after operation. You see the resolution of the unilateral hydrocephalus. We skip the same. The endoscopic monoportal partial removal also is possible, and the examples you see, but we have not so many times, so I skip this. But more interesting is the endoscopic monoportal total endoscopic removal cases. You see, for example, endoscopic colloid cyst is most common, most popular indication for this kind of surgery. And you see the example of the colloid cyst. This is navigation of the entry point for rigid endoscope. You see the foramen of Monroe and this colloid cyst inside. And first one, we little bit open the wall of the colloid cyst by coagulation of the colloid plexus. Open by coagulation of the, and then we open the wall of the colloid cyst. We cut by scissors. This is beam manual technique. It's possible only for LOTA endoscope. We very widely open the wall of the cyst. And then we remove the contents of the colloid cyst by aspirate, by forceps. And after that, it's possible aspiration of the colloid contents. And after that, it's possible to mobilize very easy the colloid cyst from the third ventricle. You see now it's very easy. After we use biportal technique and cut the choroidea and peduncle and totally removed colloid cyst. Bimanual technique. After surgery. Another very interesting case, for example, this is the choleplexus papilloma, just blocks the posterior part of third ventricle, and not so easy case because very small baby, only 3 months. The possibility for open surgery is very limited because it's very traumatic surgery. Will be so I decide to remove by from one pore endoscopically. You see, I go inside of the third ventricle, and first one I create the ETV because I don't know not possible to remove the tumor. So why ETV is economic variant of the surgery. First one, ETV without any problem. For vertical for dilatation of the stoma, restore the circulation first step. This is the basilar artery. And then after we go to the third ventricle just to try to remove the tumor. You see the tumor, Again, manual technique, calculations, reading piece by piece. And now by portal technique, you see like a microscope manual. And then we remove this tumor completely total. Pure endoscope. Through one barhole, just diameter of the barhole is only 4-6 millimeters. You see after operation, total removing, no problem, no blood. This is after operation, total removing. And 2 days after operation, this child discharged from the hospital. You see only a very small incision. It's really minimally invasive, really pure endoscopic. We published this case on the GNS. Also, interesting, the technique is about hamartoma, because localization of hamartoma is third ventricle is very difficult to the open surgery. So why we decided to remove endoscopically for one barhole. We create one barhole, go inside the lateral ventricle, and then go inside of the third ventricle. This is we are inside of the third ventricle. This is lateral wall of the third ventricle, and we disconnect the hamartoma from the wall of the third ventricle. And then, piece by piece, we remove completely total hamartoma from outside from the third ventricle. You see, piece by piece, piece by piece. And you see now completely total remove because you see that the mammillary body is open. So tumor completely, you see the mammillary body, tumor completely gone after operation. No tumor and the seizure disappear. Another our possibilities is endoscopic biportal total endoscopic pure removal. With another case, for example, we see the big tumor inside the third ventricle and growth to the lateral ventricle also. Also, it's possible to remove. This is biportal approach. And you see we dissect very carefully and use the biportal technique. And from one port, we use the Liga-Shu instrument, is special forceps with the possibility of coagulation and cutting. So why it gives us possibility very safely and very fastly to remove past tumor piece by piece. You see, I show now. You see, this is Liga-Shu forceps. You just clamp, coagulate, cut, and then after remove a piece of tumor. Again, apply this Liga-Shu forceps. You see, clamp, coagulate, then cut, and then remove again. So piece by piece, very fastly and safe, it's possible to remove from biportal approach with Liga-Shu technology. You see. Total endoscopic removal after. This is another case of biportal endoscopic removal. And in this situation, we have big peduncle with big vessels. So why I a little bit afraid to use coagulation like this. So I introduce from another port endoscopic clipata and clip all vessels by the clips. You see the clips, because the vessels is very big. So a little bit afraid. So must safely use this device. And then cut peduncle and remove totally. This is after operation. So for 5 days after operation, discharge to home. Really minimally invasive. Only 2 ports. Yeah. Another, so no limit. So if you have even like this, also possible to treat endoscopically. Just only 2 hours. 1 hour one side, 1 hour second side. Again, it's again the technology created by very careful dissection and of the peduncle of the tumors, and you must dissect vessel and carefully coagulate the vessel, and then cut. Dissect the vessel for the tumors, coagulate, and then cut coagulation vessels. This is very safe, very bladeless, and very fast technique. You see, again, coagulate, dissect, and then cut. Peduncle. And then, after you cut completely all vessels, peduncles, you remove tumor like this. Even big, large tumors possible to remove by this technology. And this is one side, and this is another second side, second ventricle, also possible like this, same technology. You see, same technology. Total removing. And another now, we have new possibility, another level of the endoscopic treatment. We've used a combination of the technology, for example, endoscopic and laser resection or biopsy. For example, hamartoma interpeninsular cistern. We create the trajectory, we put inside endoscope. From in Monroe, go inside of the third ventricle, you see the tumor, and then we use laser, vaporize most part of the tumors, take a biopsy, and piece by piece we remove vaporization part of the tumor, of the hamartoma. Seizure disappear. After surgery. This is the hamartoma of pineal region. We don't know before the histology, so why at first we create the ETV, for example. When this is the typical ETV, when we put inside the flexible endoscope, and for flexible endoscope, we create some piece of the for biopsy, big piece for biopsy, and some and destroy the tumor cells. This operation also we done from one bar hole because we use rigid and flexible endoscope both zusammen. After color is not so interesting, I think I showed before. And also maybe a last case, also very interesting case, very small baby, just only 10 months, and you see the inside the tumor, inside of the body of the ventricle. Also, we use combined technology. We calculate the trajectory to the occipital horn entry point. This is the point, is the tumor point. And you see, we will go by the endoscope inside of the ventricle. Now inside of the ventricle through the posterior approach, and we go to the anterior horn, and we in the body of the lateral ventricle we see the tumor. This is choroid plexus, so we would realize as the main landmark inside of the lateral ventricle. This is the left lateral ventricle. Septum pellucidum, nucleus caudatus, tumor. We put inside a little bit solution just to open the cavity of the ventricle. And you see, now we put inside the laser tube. You see the laser inside, and then we start to vaporize the tumor. Very easy, very fastly, very safely, and without big blood. Vaporization start. Take biopsy. Take biopsy. With this purpose, we introduce inside of the working canal some forceps, like this, and take biopsy. Coagulate again, and now it's completely total removing by vaporization, laser ablation, the tumor inside the lateral ventricle. Really minimally invasive because this was the size of endoscope is near the 1.5 millimeter. Even bar hole, no need. Even bar hole, no need. It's really a stitchless neuroendoscopy possibility. Really stitchless neuroendoscopy without even bar hole. You see, completely total removal. No tumor inside. This is our computation. It's not so serious, only transient, and only for our first steps. Also, most important for the endoscopic surgeons, how to manage bleeding. So we have a lot of technology, dry field, cavernoma, and so on. For example, we create the cavernoma technique I want to show. Colloidal surgery. Colloidal surgery, but something happened. You see the blood. You must stop. So create the caverna by the sheet. This is caverna and irrigate. And now we very clearly see the place and coagulate this place very precisely. You see? And stop bleeding, very easy. And then continue surgery. And remove colloid cyst. This is example. So we have advantages, we have disadvantages, but the perspective of this technology is very big now. But we need long course for surgeon. For this purpose, we have the special training system, and we have the special cadaver lab.
Each workplace is a mini operating room that is fitted with all the necessary modern equipment. Here, residents or young specialists can practice their manual skills and conduct scientific research or do
This is
educational
3D lab,
activities in whatever
completely
field they
full
need to
3D.
work in the operating theater. Here, all research, all training is conducted using 3D technology. This is the central working station where demonstration dissections are performed by the instructor, and the image is transmitted from the central microscope to every monitor at the workplaces. We use this laboratory not only for education, but also for scientific research and the development of new surgical methods. In particular, a miracle is taking place right now in front of your eyes, the mystery of transposition of the pituitary gland. Thus, we can develop new types of surgeries that will heal thousands of hopeless patients.
Okay, we open for collaboration, we open for residence, for fellowship. We have YouTube channels with our technology. Thank you very much. Thank you for your attention.
Thank you very much, Albert Sofiano, for this great talk. Actually, are doing a great job, and thank you for educating candidates in the Federal Center of Neurosurgery in Russia. Now I have the pleasure and the honor to introduce my good friend.
Nasir, before you introduce dear Borba, I want to say a few words about this beautiful presentation from Albert. And this is absolutely fascinating, Albert, what you showed about intraventricular surgery, the kind of endoscopes, the kind of laser technology, the kinds of things that you have showed is absolutely, I have not seen anything like this anywhere in the world. And I congratulate you on building this absolute fantastic for the next generation, maybe, if I have to say. Okay, Nasir, please go ahead.
Thank you, and thank you
very much.
And thank you, Sofianov. I know that you have another course today, but thank you for being committed to come in time and give your live presentation. Thank you very much.
Okay, thank you. Welcome. I open for collaboration.
Thank you very much. See you again. And I now have the honor and pleasure to introduce my good friend and dear brother, Professor Louis Borba. He is a well-known skull-based neurosurgeon. I don't think he needs any introduction. But let me congratulate Luis Borba for becoming the chairman of the Education and the Training Committee of the World Federation of Neurosurgical Societies. And actually, we'll have a series of webinars we do together. And our first webinar is going to be on January 14th, Friday at the same time. And it's going to be hydrocephalus. It's going to be webinar number 57 in my series. And the first webinar in our collaboration with Professor Luis Borba. Thank you very much.
Yeah, Luis.
Can you hear me?
Yes, yes, we can hear you. Put your screen on.
Okay. Okay, great. Thank you.
Thank you, Luis, for joining. And you are the friend of everybody. You can see everybody has a smile on their faces when you start, when you appear and when you start talking. So, Luis, please go ahead.
Thank you, Professor Goel. Thank you, Professor Nasser. It's very difficult to me to speak after Professor Goel, Professor Albert Sufyanov, my boss in Russia. Let's, 1 second. Okay, 1 second here. I'm fighting the computer here. I'm not used to Zoom, you know. I'm just beginning the era today. Okay. Today, the era of meningioma treatment. We used to have this sentence in our mind during many years. Since Professor, the greatest, Harvey Cushing, to now. Nothing is more gratifying than a radical removal of meningioma with neurological preservation. This is our goal as a neurosurgeon. This is our goal as a doctor, to do what we believe that's the best for the patient. Not just the tool that I have, the tool that I need to use. The goal is to do the best for the patient. Nothing is more gratifying in neurosurgery than this. You take crâniocervical junction meningioma. I'm not talking about approach. I'm talking about the philosophy to treatment. Remove the tumor, preserve the nerve, preserve the artery, remove all the attachment area, and live a new life. Nothing is better than this. A patient that's coming from far away from Brazil, from very poor area, with a giant tumor like this, tetraparesis, lower cranial nerve deficit, and the patient was told by the doctor, you're ready to die. And you do the surgery, use the approach. In this situation, I use the Petrov approach, but not, this is the issue. Go spend 14 hours in the operating room, remove the tumor, and save the life. Our goal as a doctor, this is how you learn in the medical school, to do the best that you can do and train to do it. But during some years, now it starts to changing, and everyone knows about the history of meningioma. Now I have 150 people online. I know that everyone has one case like this. Maybe not this size, maybe not in this location, but a meningioma. 10 years later, the tumor is the same. And the patient has history of meningioma is very difficult to predict. It's difficult to know which one you have a good result, which one you not have a good result. But sometimes people ask me, if you don't know how is the evolution of the tumor, how they predict the future, what to treat? Why to remove a tumor like this? Don't know why? Because you cannot lose the time that we have the plane with the structure. As Professor Vladimir just showed, the arachnoid plane is the trick to get a radical and safe removal and maybe cure the patient. You cannot leave this patient lose this arachnoid plane despite of very low symptoms, very few symptoms. No, the time is very important. Let's show you what's happened with this patient. A lady, 45 years old, had 6 nerve palsy and came to the hospital with this mess. There was a plane. See? And after talk, the doctor will go back home, talk with another doctor, surgery. Let's wait and see, maybe give you radiation, maybe do something, maybe look for kind of medical treatment or no medical treatment is very common in my area. See? Maybe it's common in other area also. The patient came back in 19 like this, now losing the plane. It's not the same situation that was. It came the pandemic time, and now tumors coming like this. The surgery that was possible to do in 17 with low morbidity. If we do now, I'm sure you have much morbidity. You cannot lose the time to say the best treatment for the patient. Today, the people talk about approach. I just saw very wonderful, very nice presentation from many experts around the world. And there is some area that is confused, you know? The petroclival area, anteropetrose, posterior-petrose, retrosigmoid approach, endonasal. I not care about approach. I care about how is your goal? How is your goal to treat meningioma of the skull base? Maximal removal with preservation of function. If you can go and remove total, it's okay. But if you can go, you cannot remove, it's okay also. But you cannot do the surgery just because you have a new tool. In this new tool, you make the goal for you. Show this case here. Man, if you look like this, through the mouth, through the nose, it's directly. Maybe good idea. I don't do, I believe that intradural tumor has to be treated with intradural approach, extradural tumor that going outside to inside, to use extradural approach. In some situations, the exception is the craniopharyngioma that gives you the root coming from the nose. But this case, they decide to do transnasal, endoscopic transnasal. It's okay. You go there, remove the tumor. Yeah. We know that the anatomy of the anterior part is 8.8 millimeters. Is the corridor. Who gave this corridor was not me. Who talk about this corridor or not me? Is the people that is doing endoscopy. They did the anatomical work And they show that the lateral limitation is the sixth nerve. But if you use the endoscope with very high magnification in 30 degree, 45 degree, 6 degree, you can see the whole world through the nose. Maybe convective meningioma you can see through the nose in the future. But what is your goal situation? To remove the tumor or just bite or remove a little bit and leave the part there? But to make me more curious is this. They did the surgery. They didn't remove the tumor. They removed the bone. And maybe this patient now, I'm not sure, but maybe the Professor Go can say that is unstable. It's mean for me is minimally invasive surgical approach plus minimal lesion. If you don't know how to do the approach, don't try. See, go to the lab and go to learn how to do the surgical approach. Neurosurgeons need to train. And the way to train, as Professor Surfianos that show, is go to the lab. Let's come back again to the petroclival area. Okay, 6.6 nerve is a good approach for tumor like this. Look at the size of the tumor, 2 grams. But the great majority of the tumor in my area, in your area, is like this. And sometimes the patient weighs too much, the tumor is like this. Let's see, what do you do through the nose? What are you do through the nose? What's the advantage to bite the tumor from the nose and remove medial part? What's the advantage to go anterior and after come lateral that you can do one approach? Maybe the philosophy of the people in this situation is partial removal. But don't talk about radical removal. We know that they cannot take it. We know they cannot take it. Now it's coming radiosurgery, radiation therapy to everybody. If you go there and burn. My mentor, Professor Almefti, say that never radiosurgery for anything. No radiosurgery. But let's talk. It's not this way, as my mentor say. Look this hemangiocavernoma inside the cavernocyte. Disappear of radiosurgery. Look this trigeminal schwannoma. You didn't cure, but you see some effect. You really see. You see the difference here? Inside is different, the tumor is different. But look the meningioma. It's very rare to have one case that change a little bit, but 90% of the cases like this doesn't change anything. But it means control. It is control. Let's choose the best case to the best tool. Maybe here, if you don't have a training experience in cavernous science, you can do radiosurgery. Here, I'm not sure that you should do. I never send patients to radiosurgery with trigeminal schwannoma, but you can see the result. Maybe the future, this trigeminal schwannoma, you come back, will start to grow again, but you can see the image. Meningioma, you don't see anything. Like the old lady, 10 years follow-up without change. If that lady had been treated for radiosurgery, was the best result ever. We know that the radiosurgery radiation therapy in general works. I mean, of course, you gain some time, but it's a matter of time to transformation, or is natural history of the disease. What you are seeing more and more often today is tumor like this. I have a tumor in the middle fossa, was operated, remain one piece inside the cavernous sinus. Okay. Superior orbital fusion invaded. Okay. Leave the tumor there. And in advance, give radiation therapy. It was okay. But now you are seeing this case that is coming back with very radical and very growth tumor, like a transformation, like a cat transformed in lion. And my question here to all of you, we transform this cat in lion. If you wait and see sometimes the natural history of this remaining tumor, maybe will not stay very slow growing benign meningioma. We know that radiation has a lot of molecular and genetic changes. We know radiation is good for several pathologies, but are you sure that's safe for meningioma? I'm not sure. There is another issue that we are seeing today is very, very often in the world, parasagittal meningioma, that you can do a surgery parasagittal meningioma in any part of the world. You don't need any fancy technology. You can go there, remain a small piece inside the sinus, on the lateral wall of the sinus, okay. It was not possible to remove the sinus, superior sagittal sinus was open. You can leave one piece. I try to remove. Sometimes I reconstruct, but if you leave, it's okay, no problem. But today, everybody is doing this in the world, especially in developed countries that they say that they are developed countries, that you want to say this to the world, give radiation. And what is happening is this. If you talk with the guy from radiation therapy, they say, oh, venous congestion. Never radiation effect. But maybe radiation effect. We know it. But one thing that I saw in this case, and I follow another case that was very important in this situation. After radiation, there is no venous outflow. This venous congestion is because of this patient has no venous anatomy that's suitable for this, or the radiation had some effect in close the outflow venous. This is the question that is seen. When you see a case like this, very similar situation, complete asymptomatic. This patient was operated 10 years ago. I have very bright neurosurgeon in Brazil, had infection, okay, lost the plate of craniotomy. The skin was terrible, how you can see here. There is no bone here. They didn't send to any kind of treatment, radiation therapy. Now, after 10 years, the patient is complete asymptomatic. You see what's happening here? Look, this vein. This vein didn't have in the pre-op. This patient was not irradiated. This patient was just wait and see. A new outflow, venous outflow. Maybe I'm asking you, the radiation therapy for these remaining tumors, maybe close this vein, maybe predict that you not have this outflow. If you don't send this patient to radiation therapy, maybe you have the possibility to open a new collateral, new venous collateral that is, see? Think about this. But we as a neurosurgeon, and I know I have a lot of residents here online. They love neurosurgery, the passion of neurosurgery, the beauty of neurosurgery. And you go to the biggest congress in the world, the AANS, American Association of Neurological Surgery. Good, great people, great guys. You go in the booth of the Lexel Gamma Knife. You see this here. Look this meningioma, Professor Tulio. Let's come back here. Look at this meningioma here. Look at the attachment. Look at the attachment, very small attachment in the tentorium. And this was the example to treat for radiosurgery, Gamma Knife. You have the same situation like you have here. See the attachment in the tentorium. You go retro supracerebellar, see? Cut the insertion, the attachment in the tentorium, completely liberate the blood supply to the tumor. You can go, now the tumor is totally free. If you can follow the dissection, and in the end, you have like this. You remove a ball, the very simple approach that you can do every day, everywhere, without see, the necessity to give radiation. And also can go to the tentorium and remove widely the tentorium. Why the example for the Gamma Knife was that case? Why don't show a crazy case? Do you know why? Because it's the simple case. It's the pre and post-op. We know that radiation induced meningioma. I always like to remember, after the Second War, the people that moved to Israel. And that time, they treat tinea captis with very low doses. I say very low doses of radiation, 150 Hz. Now what's happened? Radiation-induced meningioma. As Professor Felix Umansky from Israel showed during many years around in the Congress around the world. Now you have more and more confused. The literature is making us crazy. Okay, radiation-induced meningioma need to treat radiation therapy. Okay, maybe okay. If you cannot remove, it's okay. But if you go to the paper and look at the example from this paper, my friend, this is the example to treat radiation-induced meningioma with radiation therapy. This tumor, you can give not 2 centimeters margin, as Professor Borovich said many years ago, and Professor Messi said grade 0 removal. You can give 10 centimeters margin. You can remove all this area without the necessity to burn the brain again. I didn't show the authors, because if I show the authors, maybe some of you have a heart attack. Why we don't introduce this new concept that Professor Almesti many years introduced? They couldn't publish. They found so many difficulties in the paper. It was very difficult to publish. But now the people came and show. Natural history of cavernosinus meningioma. I talk about cavernosinus meningioma, the tumor that is inside the cavernosinus, not in the lateral walls of the cavernosinus, not the tumor is compressed in the optic nerve, not the tumor that is coming from outside to inside. I say cavernosinus meningioma. It's the paper people from France. 78% regression symptoms with corticosteroids. Okay? 90% no relapse of symptoms, mean follow-up 10 years. Growth of cavernosinus meningioma, 19% increase, 71% is stable, 9.4% decrease. These numbers are very similar to one very famous treatment that everybody knows who is. And you see the 5 cases that fail the wait and see treatment. Radiation, radiosurgery, radiation therapy. 4 didn't change, 1 decrease. Okay, but a new meningioma, radiation-induced meningioma came for the treatment of radiation or radiosurgery or radiation therapy. We know today that you are treating patients that doesn't need treatment. You know today you are doing surgery and the patient doesn't need surgery. We know today that if you wait and see, maybe the best to your patient. Maybe also, I believe that the best to your patient to have a tumor in the cavernosinus that invaded the superior orbital tissue in my hand. I know that some people in the world can do, but I say I cannot do. I prefer to leave this small piece in the superior orbital tissue and the patient remain the mobility. You just follow and see what's happening with this tumor. Maybe if tumors start to grow, maybe not. Wait and see. Patient, patient. Sometimes you have a patient like this, 66-year-old female, no neurological deficit, just headache. What does this patient need? The ophthalmologist say no visual deficit, no visual loss, no mobility or ocular mobility deficit, completely asymptomatic this lesion. This patient needs treatment. What kind of treatment you can do? You do surgery, of course. We'll come with diplopia. You not remove everything. Radiosurgery, here there is bone. You burn the bone. This patient needs to run away from the neurosurgeon and from the radiosurgeon. In conclusion, I want to say to all of you, the history starts to show that the treatment of meningioma, there is a new way. And the new way may be the best way. The best way is to do the best for the patient. It does not mean that the best for the equipment, best for the doctor. We need to treat patient, not image. You should believe and you know that the only curative treatment is the radical surgical removal, but not always is possible. Let's try to use the approach that is most adequate to that lesion, not the approach that is fancy, is new, has beautiful videos, has beautiful photos. We need to study the genetic and hormone expression is very important. The genetic is very important. The behavior of the meningioma is crucial for the decision maker. And the most important thing, if you have doubt what kind of treatment you do, what kind of approach that you do, if you need or no advantage, wait and see. Wait and see that sometimes the time is the better for the patient with the action of God. Thank you, Professor Nasser. Thank you, all of you. I believe that neurosurgery is commitment. Neurosurgery is focus. Neurosurgery is passion. But neurosurgery, medicine, and we as a doctor, we need judgment. The best way to treat, to do, the patient has to be very, very, very well studied. I want to invite you for real. We just saw in the media now a new variant that's coming now from Africa, South Africa. Maybe next month, the new variant is coming from Brazil for any science. It's crazy. The world is completely crazy. But our meeting is still on and will be on in Brazil, March 23 to 27. Brazil has today 80% of the population totally vaccinated, 80. See? The adult population is almost totally vaccinated. The hospital is completely empty of COVID. The people are going to the beach. The people are going to the party. The people are going happy. I believe that in March, you will meet in the beautiful city of Rio de Janeiro to have fun. A nice caipirinha, a nice wine for our friends, Argentina and Chile, and the best meat in the world, the Brazilian meeting. Thank you very much, and sorry for the long time. Thank you.
Thank you, Dr. Luis Borba. From a technical neurosurgeon, you have become a philosophical neurosurgeon. From the knife, you have gone to no knife. And from no knife, you have gone to philosophy. So this is philosophy, science of all sciences. And your very strong messages, your strong words are indeed very effective to the world of neurosurgery. And many young people, Nasir, are watching this show, and they will be influenced by this very nice and basic lecture.
Yes, yes. Thank you very much, Louis. A great presentation as usual. Thank you.
Now it is one of my great honors and great pleasures to introduce Professor Giuseppe Lanzino. Everybody knows him, but I have to introduce him, so I have to introduce him. He is from Mayo Clinic, and he is another philosophers, Louis, another philosophers of neurosurgery, another thinker of neurosurgery, another ambitious, dedicated soul of neurosurgery. The way he works, the way he writes, the way he influences others to do good neurosurgery, to write papers, to think about neurosurgery is unparalleled in the world of neurosurgery. He's my good friend. He's my younger brother for a long time. Actually, we were together working with each other. If it will not be wrong to say that it was Giuseppe who influenced me to do whatever I have done in my life and in my career. Giuseppe Lanzino. Please go ahead, Giuseppe. Unmute. Giuseppe, unmute.
Thank you for the kind introduction. Great honor to be here with all of you and humbling to follow such esteemed group of speakers, and congratulations for pushing this incredible series of webinar further. I will, my presentation complements a little bit what has been said before, and particularly what Dr. Ongo very eloquently showed. So why brainstem cavernous malformations? I think because brainstem cavernous malformations, it's one of those situations that really allow us to put it all together. The understanding of the problem, the understanding of the pathology, the clinical condition of the patient, the understanding of the anatomy, and then the understanding of the anatomy in relation to the pathology, and then the choice of the best approach. So there are two main phases that we go through every major neurosurgical problem. Number one, when to operate. And we have heard a lot of thinking about this issue, but you cannot stress hard enough how that is important, especially when we think about brainstem cavernous malformation. This is a slide that I borrow from my colleague, Kelly Fleming, who works here at Mayo. We have a prospective database with over 400 patients with cavernous malformations that we started in 2015. And we can see that in patients who presented with hemorrhage, there is definitely a much higher incidence of rehemorrhage in patients who have brainstem cavernous malformations in relation to those that have non-brainstem location. So when to operate? Well, a patient who presents with hemorrhage is a patient where the question we should start thinking about whether or not it's indicated to operate, and then we can discuss whether we should wait for another bleed or just go in after the first symptomatic episode. Now, once we have understood when to operate, then the next question is how we're going to do it, how to operate. So when we think about how to operate, of course, we stress a lot the fact that we like to identify an area of the lesion which comes closest to a brain or ependymal surface, because that will allow us to get to the lesion without violating normal brain. But it's not only the area that comes closest to the surface, but especially for brainstem cavernous malformation, which, as I will show, we often span multiple compartments, we have to identify an ideal trajectory to improve visualization, but also facilitate resection of what we might anticipate is the most difficult portion of the lesion. And as we know, many brainstem cavernous malformations, we like to talk about mesencephalic, pontine, medullary, but the truth is that often you deal with the lesions that span different compartments. We can also learn a lot, and Dr. Hongo showed a case that really illustrates this. The symptoms, but also the clinical progression give us a lot of information about where the lesion starts, and then what is the pattern of expansion, as these lesions often have multiple bleed. We all fall into the same trap, in the sense that we always talk about, especially brainstem cavernous malformations. Basically, we can use most of the approach known to mankind. But the truth is that in reality, we often tend to fall into the same trap, that we tend to prefer the type of approach, the type of approach that we are more familiar with. And then the issue on how and when to operate, they are really often all mixed together. How soon should we go and offer surgery after a new hemorrhage? The problem with doing surgery immediately after a new hemorrhage is that there is often surrounding edema, and the edema leads to softening of the surrounding brainstem parenchyma, and therefore the brainstem becomes easier to damage as it's all swollen. And if we wait often just a couple of weeks, then we allow not only for the hemorrhagic portion to liquefy, but also for a little bit of hemosiderin ring to form around the lesion. And as the edema resolves and the hemosiderin forms, that creates some degree of gliosis, which in theory should increase the resistance to damage. And I would say that there is overall agreement that if you can, maybe waiting a couple of weeks after in presenting bleed might be the best time to intervene. But at the same time, there are a lot of options. Because if you wait too long, then you might form the formation of adherence between the cavernous malformation capsule and the surrounding brain. Now, it's important also to recall ourselves when we think about the approach. You look at this and you say, wow, gee, this is really into the fourth ventricle. But it's important to remind ourselves that the cavernous malformation, as they bleed, they tend to displace rather than destroying the surrounding parenchyma. And therefore, when we think about our approach, it's very important to realize that there is often a much larger rim of normal parenchyma than the MRI might lead us to believe, because the parenchyma might be really thinned out and pushed out, displaced by the cavernous malformation. And look at this same patient after removal of the lesion. Look how much floor of the fourth ventricle was there. So I agree with what Dr. Rongo said. Over time, I realized that for pontine pontomesencephalic cavernous malformations, if you can go through a more anterior, anterolateral, or posterolateral trajectory rather than through the floor of the fourth ventricle, unless there is a true extrinsic component that goes through the floor of the fourth ventricle and the patient does a sixth and a seventh, then I agree that as much as possible, I think it's probably better to avoid going through the floor of the fourth ventricle. Now, I think it's important in the decision of when to operate to make this distinction that Professor Konovalov stresses is between the so-called hemorrhagic type and the non-hemorrhagic type. What do I mean? Well, this is what I would consider a hemorrhagic brainstem cavernous malformation. There is a large hemorrhagic component. These are often associated with some degree of edema in the acute phase, and nowadays with the flare and special MRI sequences, we can see the amount of edema, which I've noticed also tends to get much better over the course of even only a week if you repeat the MRI. These patients that have a large hemorrhagic component that is pressing on the surrounding brain, if you do the surgery right, these patients actually might improve after surgery. Usually when we give an indication for a brainstem cavernous malformation, we are worried about the risk of worsening the patient condition. But in some of these cases, if you do the surgery right, you can see that some of these patients actually get better after your surgery. And since most of the bulk of the cavernous malformation is hemorrhagic, and often what we do, we go in with the bulk of the large hemorrhagic component. If you're not careful, some of the actual true cavernous malformation might end up in the suction, and the pathology might not be able to find the true cavernous malformation in the specimen that you sent. And this is again an example of what I would consider a hemorrhagic cavernous malformation. And then you have what I would consider the non-hemorrhagic types. These are much more difficult. You can see that there is a hemosiderin ring around the cavernous malformation that creates some, if the cavernous malformation is long-standing, creates some adhesions with the normal brain. You can see how the boundaries of this cavernous malformation are very irregular. These cavernous malformations, they usually tend to grow not through large bleeds like the previous one, but they often tend to grow and the patient can have slow progressive symptoms over time. They can grow through proliferation of some of these micro caverns rather than a true bleed. And these are the patients that have a very high risk of postoperative worsening because of the tenacious attachment to the cavernous malformation. And these are the ones that, unless, like in this case, there is a fairly large corridor where you can see this, an example of this case. So there is through the fourth ventricle, you can see that there is a very nice large corridor where you can discern the boundaries of the cavernous malformation from the surrounding hemosiderin stained brain. These cavernous malformations can be very, very difficult to remove through a narrow corridor without intercurring in some damage of the surrounding parenchyma at postoperative deficits. I like to show briefly a case before concluding that I think summarizes some of these concepts. This is a young lady who has a progressive hemosensory loss. She comes in, this is the picture, and you look at her, this beautiful young lady, all she has, it's a little bit of sensory loss, particularly in the left arm. And this gave me a big pause because you can tell this is not going to end up well if you don't do something, but at the same time, there is a natural concern about the potential for postoperative deterioration. Now, in this particular case, it was also very interesting because I thought, looking at the MRI, the inferior and more anterior portion was more hemorrhagic. At the same time, what was strange is that really she did not have a history of a sudden major deterioration. It was more like a very slow subacute progression of this numbness. Here again, how we tend to stress the technical aspects of what we do, but again, the symptomatology, the progression, we always need to know the patient and think about, because in these patients, it turns out that these were not actual true caverns filled with dull blood, that these were actually almost like massive, very large veins filled with flowing blood. And the other component here is that how do you get there? So here, I would prefer an approach that gives me a preferential view from the top down, so I can look at the entire portion of the cavernous malformation. You could say, well, some surgeons do this through a retrosigmoid approach. The problem I have with the retrosigmoid approach is that how this is going to be the most difficult part for me, the most medial portion. So I like to have a preferential view of this medial portion, and therefore, what we did in this case, and I'm lucky we have a great skull-based team with the help of my colleague Michael Link from neurosurgery and Colin Driscoll from ENT, they helped me with the approach, and we did a pre-sigmoid petrosal approach that really, you can see, gives me a beautiful view of the most lateral portion. Now I can tell where the actual cavernous malformation comes closest to the surface, and making an incision along the direction of the tract. You can see, get to the liquefied portion of the cavernous malformation. Here, what I learned is that patience in this type of surgery is very important, because once you decompress that liquefied portion, the elasticity of the parenchyma that is massively compressed will tend to push the remaining portion of the cavernous malformation into your way. And then we all know about, we are familiar with the steps of identifying the actual boundaries of the cavernous malformation. And what was surprising for me in this case, I think it was partially because of the size of this lesion, is that despite there was not a recent large hemorrhage, there was quite a bit of the surrounding parenchyma was not quite as and you can see here these large, almost like large venous components at the most anterior and inferior portion of the cavernous malformation, where I said that here the approach, I get a preferential view with the top to bottom trajectory, and also a preferential view, you can see here, of the most medial portion of the cavernous malformation, which was going closest to the fourth ventricle. So I thought this case summarized all of the aspects that have an important role in the decision making of the cavernous malformation. And as I mentioned, we tend to try to cluster these lesions all together, but my experience, they seem to be almost like one is different than the other one. And as I said, in this particular patient, there was a fairly large component, which I thought was a hemorrhagic component. Instead, they were really like almost large veins. And then with these very large ones, you get to the point where it's not so easy and straightforward to distinguish what might be Mossiderim stained brain from a little small residual cavernous malformation. And here is the comparison between the pre and the post-op. And to my great relief, this young, beautiful lady had some degree of mild worsening of her sensory deficit, but eventually she made she recovered back to her preoperative status. And again, I thank you for the honor to present along with this very esteemed panel, and congratulations again for this great series.
Thank you, Giuseppe, for this very informative talk on cavernous hemangiomas. And we are diagnosing these tumors more and more, and many talks are there on the web. And your talk has given several new thoughts and several new perspectives. So as Nasser, our next speaker is unfortunately has not joined in. What do you suggest? Should we have some discussion? Or?
Yes, of course. And I think many of our colleagues are raising hands, like Hisham Basuni from Germany, he just joined us, and we have a lot of questions of the panel over the Q&A panel.
Yeah, good evening, everybody, or good day, different parts of the world. Hello, Ahmed.
Hisham, would you open your camera, please? Dr. Hisham Basuni.
I cannot actually, because I I just can open my voice, which I've done.
Okay.
Okay, go ahead.
Maybe you can add me to the panel, then I can.
Just go ahead, Hisham. Just speak.
Yeah, I'm yeah, greeting you everybody, and I'm actually I joined a bit late, but I saw the enjoyed the presentations. Well, there are many aspects which I really can support, like on brainstem carcinomas. They are very different, and
John, can you check some problem, John?
no, I just joined.
Yes.
So on brainstem carcinomas, they're really different. I tend to operate on early because I had the experience of deterioration and very early rebleeding. Actually, I think I know the discussion about the edema surrounding the carcinoma in the very early phase, but I think it's a matter you can handle with very cautious resection of the carcinoma, and it's much worse if it's rebleeding. It's causing much more deterioration and much more damage. So this is one point. The other point, Dr. Lewis, hello. We have the same mentor. It's Professor Sam El-Mefti, and so we have a very common ideology and philosophy in skull-based meningiomas. And I share your points about resection and always try to do your best. Maybe a bit different from the philosophy of Professor Sam El-Mefti. I think there are some indications for gamma knife surgery, but they have to be tailored to the individual patient and to the case. So I would not reject gamma knife completely. Examples are cavernous sinus meningiomas, which may be very hard and very difficult to resect, and they cannot actually, in most of the cases, resect without creating new neurological deficits. So I and wait and see policy. It's good. It can be recommended in some patients. Especially in the not in the very young patients, and even there are some cases where you have to, where I would see an indication even without neurological deficits because of the proximity of the meningioma to very critical structures like the optic nerve, for example, like the internal carotid. And if you're doing surgery, you often find an en plaque extension of the meningioma to these structures, which you cannot see on the MRI preoperatively. So these are my comments. But unfortunately, I did not join the complete session. I'm sorry for that. I had a clinical conference. Thank you very much.
Thank you, Hisham, for those comments you have added to the huge list of comments from Luis and a little bit big list from Giuseppe Lanzino. Giuseppe, you are there? You're not there. Okay, next, any other question, any other comment from the panelist? Nasser?
Just looking if anyone raising hands. We have two colleagues, but I think it was long ago. They were raising their hands, but we have many questions over the. I think somebody is raising hand too. For any colleagues raising hands, please speak. You are unmuted.
Thank you, Nasser. This is Mahmoud. I think we've had a superb afternoon, and essentially for those in training, they obviously are going to look at these mesmerizing videos and mesmerizing talks and say, wow, when are we ever going to get there? But I think some of the philosophical take-home messages are from this webinar particularly, that really the days of just going, seeing the case, watching it on YouTube and trying to do it yourself with somebody are getting less. I think there is need now with most training institutions to seriously start thinking of developing cadaveric labs because the nuances are getting more complex, the approaches are getting more complex, and unless you actually spend time in the cadaveric labs, what you are seeing on these webinars will always remain very alien to you. So I think whoever is in a position of influence to get your hospital or your university to invest in a cadaveric lab, I think we need to push for that, because that is the way the younger generation is going to achieve the kind of surgeries that we have seen this afternoon. The other very valuable nuance was don't necessarily treat the images, but go for your clinical judgment based on what the patient presents with. And I think that was a very useful advice. It's always been there, but I think to reiterate it with excellent examples as Professor Borba did is very valuable. So I think we're indebted to everyone who has given this series of lectures and to those who have organized it, but I certainly enjoyed it hugely. Thank you very much.
Thank you very much.
Yeah, Nasir, go ahead.
Thank you very much, Professor Mahmoud Qureshi, for these kind words. Atul.
May I say something?
Yes, of course, please.
Yes. Now, what I will like is, I will like few comments in few lines from the panelists. First, Vlad, you would like to say a few words?
Let me welcome Virendra Sinha. He is a well-known professor of neurosurgery in India, and he's a chairman of the Neurorehabilitation and Reconstructive Neurosurgery Committee of the World Federation of Neurosurgical Societies. Thank you, Sinha, for joining. Please go ahead.
No. If you may I say something? Follow me. Is it okay?
Louis? Yes.
Yes.
Yes, please.
Okay. First of all, a great honor to be with all this, my mentors and teachers here and all together. Professor Mahmoud, when we start to work in education, you think that there is no more time to learn in the head of somebody. There is no more time to learn from somebody. We need to learn in the lab, in training. Our idea now in the Education Committee of the World Federation is to try to do this. We are organizing a series of webinars with Professor Nasser El-Ghandour. I always do the wrong. Nasser is easier, okay? That will be a webinar about petroclival meningioma now. Our idea is to start with hydrocephalus, go to trauma, go to myelomeningocele, and start from the basic to make the word just one word. It's our idea. In our committee, we select some people, and one of the points, if this guy has a lab in his institution, he has to be in the education committee, like Professor Albert Sufianov, like Dr. Diego here in Mexico, like Carolina in Miami, like the people in Morocco, Nadia and our friend Fahad, see? Because what you are learning there, the experience is unbelievable, unbelievable. And you think, I think that you need to bring back to the neurosurgeon, to the resident, the real goal why they did neurosurgery. The neurosurgery is a passion. Maybe it's the only specialty that you can leave the morning in your house and come back with a very bad result. It's the only thing that you can, is the passion that makes us completely different. And I need the help of all of you. We need in the education committee, together with Dr. Satoshi, the help of all the society. We want to go in every place. We want to go to bring, not to talk about intraoperative MRI in the poorest area of Brazil, but talk about the problems that they have there, how you can help to fix. I think you need to really make one word of us, okay? And about meningioma, a lot of controversy, I just say what I think. Everybody have his thought. Maybe you can think in the future, you can change something, or you can come back. Thank you for all the support, Dr. Nasser, and you join every month.
Thank you, sir.
Some topic, directly topic is this thing. And Atul, you are the king.
Thank you very much. Thank you, Louis. And
you are older than me, Louis.
No.
I'm totally agree with Louis just said now that we still have to train our candidates in the labs. They need to be trained on cadavers because neurosurgery is a specialty that needs to develop skills. Yes, virtual learning is something very important, but we still need the labs and we still need the hands-on workshop and the cadavers. Thank you. I think, Sina, do you like to say any comment? Sina, would you unmute your mic?
Just I want to for very small Kevadomani role of gamma knife and all.
Hongo, you may comment. Hongo, on the role of gamma knife in
for very small brainstem
for small interaction, not approachable by surgery, maybe in the depth, maybe in the center of the brainstem, where your knife may be a little bit too dangerous. What do you think about gamma knife?
Hello.
Yeah, go ahead.
Yes. Well, direct surgery to the brainstem may be good too, but sometimes harmful. If the two others in surgery, like gamma knife or any others, may contribute to treat the patient, I think it's good. But I'm not sure. There is still controversial about using gamma knife for brainstem lesion.
Yes.
I cannot say surely, but for me, for selecting the less invasive route, removing the lesion, even in the brainstem, and the surgical procedure, it's a good way, I think. Thank you.
Thank you, Hongo. Nasir, anybody has comment? Vlad, I want to hear something from you.
Yeah.
Before
there was Louis. There was an excellent lecture, very thoughtful. I just don't think that we should be that harsh to gamma knife people or cyber knife people. It doesn't really matter because radiosurgery as well as endovascular, it's integral part of neurosurgery. Those are our tools as well. We do not only have knife, we have gamma knife, we have endovascular catheters and everything. So if we keep it under ourselves or for ourselves, then it's all right. That those people are not enemies.
Yeah, I'm not saying this. I think it doesn't understand what I said, because my terrible English makes something different. I'm not saying that the radiosurgery is as to nobody. I'm saying that you cannot give a treatment because we think that you need in advance for the tumor that you have no idea what will happen sometimes. See, what you are seeing today, Professor Vladimir, in the whole world, the example is not cavernosinus meningioma, that is a difficult case. Parasagittal meningioma. The people is removed partially and burned. They are not leaving just the small part close to the sinus, inside the sinus. They leave a big piece and burn without see the behavior of the tumor, without try to remove some time. Radiosurgery is a wonderful tool. It's a wonderful tool for many, many, many pathologies. But maybe it's not so wonderful for meningioma. It's okay. You see, it does not mean that you can use to everybody. You are seeing today the people going to everybody. It's a difference.
Okay, my dear Luis. Okay. Enough of meningiomas now. And maybe parting few words from Goto. You want to say a few words?
Yes. Today, I feel very honored to join this expert meeting, and I feel that all the expert has good microanatomical knowledge and select the suitable approach to the region. So that I just comment to the young neurosurgeon, if you want to be the skull-based surgeon, anatomical study is very, very important. And today I present the endoscopic endonasal approach to the Clivus meningioma, but we also need the classical skull-based microscopic approach. So in young generation, the young neurosurgeon have to learn the microscopic skull-based surgery and endoscopic neurosurgery. This is the comment to young neurosurgeon.
Okay. Now I will like to have one comment from our local education committee chairman, Dr. Ashish Suri. Ashish.
Yeah, thank you. I think it was a wonderful display of excellence by all the faculty, and remarkable thanks to Dr. Goel and Dr. Nasir for collecting a wonderful team here. I think I agree with Dr. Goto that that a modern skull-based surgeon, the new skull-based surgeon, has to be a master of both microscope and endoscope. Second, master of skills has to be it is a continuum. I think one or two skull-based dissection workshops actually don't make the thing. It is ultimately you have to attend many. You have to maybe teach. When I was learning with Winko Dollins, I realized that it is a continuum, and still now I go back to the lab to see how the sixth nerve behaves just inside the Dollock-Bendorf canal or something like that. So these minor things you have to have. I think yes, I'm into a lot of research and simulation, but virtual and 3D printing and all these models are good. They can give you some, but there's nothing like real life and cadaver dissection. So I think this is a must.
I think we must wrap it up. You just give some comments and so we wrap it up. Okay, Nasir?
Yes, I think I now invite Professor Atul Goel to say his closing remarks. Do you like to take any questions, Atul, or you want to finish the webinar now?
I think we'll like to finish because we had enough of philosophy from Luis. And if I hear any more word from Luis, I may faint. And thank you very much, Luis, in any case. And thank you, speakers, for this wonderful educational program. There have been many.
At the end of this webinar, I would like to thank Professor Atul Goel for the opportunity to have such wonderful collaboration. It's one of the best webinars we have been organizing I would like to thank all our distinguished speakers for the time and for the experience they gave us today. And I apologize that not all the questions over the panel we were able to answer because of the benefit of time. I also apologize that we extended the webinar for 1 more hour, but actually the discussion was very interesting. Our next event will be webinar 55. It's going to be Friday, 10th December, a collaboration with Miami University. May I not forget the IT team, my team who worked hard and they are doing actually a great job. And as I promised, for all attendees, the certificates will be sent automatically tomorrow to their emails. Thanks to Hassan Ala and Ahmed Magdi for the great job they are doing. Thanks to all of you and hope to see all of you again soon in another occasion. Thank you very much.
Thank you. Thank you very
Thank
much.
you.
Thank you, everyone.
Hi, Hogo.
Thank you.
And healthy.
Hi.
Thank you.
Thank you. Thank you.
Thank you.
How are you, Dr. Goto? Bye.